Okay, and the slides are clear. Can you see my slides? Okay, perfect. So I'll start by introducing myself. I'm Antoine El Khouri. I'm a cardiologist. I'm originally from Lebanon. I currently work in France. So I want to say thank you to the organizer for organizing this event. And today I will give you two lectures this morning. So the first one will be about introduction to ECG interpretation, and the second one will be about how to manage patient with unstable hemodynamics. And then my colleagues will continue with the rest of the lecture after that. So the first lecture, it's about ECG basics. So first of all, you need to understand how the electrical conduction in the heart functions. So we have the sinoatrial node, which is the main pacemaker cell of the heart. So the electrical activity will originate in the sinoatrial node. Then it will propagate to reach the atrioventricular node, the AV node, which is the second pacemaker cell of the heart. So it will propagate in the atria at the beginning, so right atria and left atria via the Bachmann bundle. So all the electrical activity will propagate to both atria simultaneously. Then after reaching the AV node, the electrical conduction will go to the ventricles. So we have the His bundle, and then we have the left bundle branch and the right bundle branch. And then we have the Purkinje fibers, which will go to depolarize the ventricular cells. So that's how we generate the electrical activity in the heart, and that's how it will allow for the contraction of the myocardial cell in order for the heart to function. So we need to generate electrical activity. So to do an electrocardiogram, how to record this electrical activity? We record it by doing an electrocardiogram. So as you know, we have 12 lead electrocardiogram. So we need to place 4 electrodes on the limbs. So we have the right arm, left arm, left leg, and right leg. And we need to place 6 electrodes on the precordium. So V1, V2, V3, V4, V5, V6. So we need to place all of these electrodes in order to generate a 12-lead electrocardiogram. So I will show you where to place these electrodes. So uh, from V1 to V6, so you need to put them on the V1, V2 on the fourth intercostal space, then V4, V5, V6 on the fifth intercostal space, more laterally. And V3, you put it in between V2 and V4. So this will record the precordial lead, so from V1 to V6. Then you have the right arm, left arm, and right leg and left leg. So we have these additional limb electrodes. We call them limb electrodes. So we placed 10 electrodes in order to generate a 12-lead electrocardiogram. Then, if we want to analyze the ECG in further detail, you can place the right-sided electrodes. So, uh, what we call them V1R, V2R, V3R, V4R, V5R, and V6R. This electrode will record the electrical activity mainly on the right-sided of the heart, so the right-sided cavity, the right ventricle, when we suspect myocardial infarction involving the right side of the heart. So when we suspect this, we need to also do the ECG, the right-sided electrodes, in order to visualize the changes in this territory, so the territory of the right cavities of the heart. Sometimes we can just put just one, the V4R, so it will give us an idea also what's going on the right heart. So you put the usual V1 to V6 electrode normally, and then also you place the V4R, so you put an additional electrode. So we have in total here 7 precordial electrodes in addition to the limb electrode. So we'll have here is 13 lead ECG instead of 12, because we will see also the V4R, the right-sided electrode. Also, if we want to go deeper, we can place 3 electrodes on the back of the patient. This will record the posterior electrocardiogram, so to reflect the posterior wall of the heart. So V7, V8, and V9, we can place them on the posterior chest wall. V7 will be placed on the axillary line in the same horizontal plane of V6. So when we put V6, and then you place an electrode posteriorly just on the back, but on the same level of V6 that we put anteriorly, but V7 will be posteriorly. Then V8 will be just next to V7 on the same horizontal line, and V9 will be also on the same horizontal line, but on the left paraspinal region. So it's median in the near the spine. You put V9. When we put these 3 electrodes, we will be able to record the electrical activity on the posterior wall of the heart. So now we covered all the possible placement of electrodes. So we said we have the usual electrodes that we do in order to generate the 12 lead ECG. And if we want to do the right-sided electrode, we can place them here, so on the right side of the chest. And if we want to record the posterior wall of the heart, we can place electrodes, also 3 electrodes on the posterior chest wall in order to record the posterior wall of the heart. And now, when we do the ECG, if you look on the ECG, on the 12 leads of the ECG, if we find changes on this ECG, we can know which wall specifically is abnormal in the heart. So if you look on lead 1, AVL, V5, and V6, this will reflect the lateral left ventricular wall. So if we find changes on these electrodes, we can suspect that there's an anomaly involving the lateral left ventricle. So just this segment of the left ventricle. While if you look on lead 2, 3, and AVF, these three leads will give us an idea on the inferior portion of the left ventricle. So here is the inferior wall of the left ventricle. And usually this inferior wall is having blood supply from the right coronary artery most of the times. While the lateral left ventricle, we said 1, AVL, V5, V6, usually it's the left circumflex artery. So it's another artery giving blood supply, because you need blood supply in order to generate this electrical activity of the heart. While if you look on leads V1, V2, so it's here the V1, V2, V3, and V4, it's the anteroseptum. So it's the anteroseptal wall of the left ventricle, and the blood supply going to this region is from the left anterior descending artery. So we have each wall is of the left ventricle have different ECG leads, and each wall is getting blood supply from different coronary artery. Now, when we want to analyze the ECG deeply, you can see we have the P wave, you have the QRS complex, and you have the T wave. So when we look on the PR interval, so the PR interval is very important. This interval reflects the depolarization of the left of the atria, right and left atrium. So in order to analyze the atrial activity and the conduction from the SA node to the AV node, you always look on the PR interval in order to do that. Then you have the QRS complex. So the QRS complex reflects the ventricular depolarization, so the ventricular contraction. So any abnormalities in the electrical conduction to the ventricle will have abnormalities of the QRS complex. And then you have the QT interval and the T wave, so it reflects the ventricular repolarization or relaxation of the ventricle. So after the ventricular contraction, the phase just after the ventricular depolarization or contraction, we call it ventricular repolarization. So this is briefly each electrical complex, how we can divide it. So now when you look on the ECG paper, you need to know that each small square on the ECG paper is 40 milliseconds. So it has a duration of 40 milliseconds or 0.04 seconds. And each big square, so I will put the pointer. So each big square, so it contains 5 small boxes. So this is 200 milliseconds, okay? So the small box is 0.04 or 40 milliseconds, and so the big box is 5 small squares, so it's 200 milliseconds. This is very important, okay? So when you look on the standard paper of the ECG, the speed of the recording is 25 millimeter per second. Okay, so when we want to measure the heart rate, it's very important to know how to measure the heart rate on the surface ECG, because there's a tool to measure the heart rate. So when you look on the ECG paper, and in order to measure the heart rate, you have two methods. Either you count how many big boxes are present between two consecutive intervals. So if you look here, for example, we have 5 big boxes. So 1, 2, 3, 4. So we have four, sorry. So here we have 4 big boxes. So in order to calculate the heart rate here, you use the 300 divided by number of big boxes. So 300 divided by 4, here it's 75 beats per minute. While if you have just, for example, here, if you have just two big squares between two successive QRS complexes, so in that case, the heart rate will be 300 divided by 2. It will be 150 beats per minute. And if you have 5 big boxes between two QRS complex like we see here, so here's the heart rate will be 300 divided by 5. It will be 60 beats per minute. So the more big boxes we have between two QRS consecutive complexes, the lower the heart rate will be. Okay. There's another more accurate method. So instead of using the 300, we use the 1500 here. It's more accurate because here we are using the small squares. So using small squares is more accurate. It will give you a heart rate. Why 1500? Because here we have 300 and we use the big boxes. We want to use the small boxes, we said big 500. So if you want to calculate the heart rate, so here it's 1500 divided by the number of small boxes. For example, here we have 10 small boxes. So it will be 1500 divided by 10. We will have 150 beats per minute as a heart rate. So it's the same tool, but here it's more accurate because we are using the small squares method instead of using the big squares method. So this is how we calculate the heart rate. Either 300 divided by big boxes between two consecutive intervals, or 1500 divided by the number of small boxes between two consecutive complexes. Okay? Is it clear for now? Any questions? You're hearing me well, right? Can you hear me? Please, can you write yes if you're hearing me? Okay, perfect. So we'll continue. So when we measure the heart rate, you need to know the normal value. So in a normal adult, the normal heart rate will be between 50 to 100 beats per minute. So 50 to 100. And when we say tachycardia, it should be above 100 beats per minute. And when we say bradycardia, it should be less than 50 beats per minute. It's different in newborns because in pediatrics population, the heart rate is a bit different. So normally the heart rate is between 110 to 150 in newborns. When they grow up in age, the heart rate tends to drop a bit. And when we reach 6 years plus, it becomes like the adult, so between 60 to 100 beats per minute. So when we say sinus rhythm means that we have a P wave here, then a QRS, then a T wave, and it will repeat. We'll have the same pattern repeating. And if you calculate the duration from here to here, it's the same from the duration from here to here. So The definition of sinus rhythm is a rhythm containing P waves with regular intervals. So the intervals are the same from each complex to a complex. We have the same duration, and we have clear P waves followed by clear QRS followed by T wave, and the heart rate should be between 50 to 100 beats per minute. When we have the same pattern, so we have the presence of P waves and we have a regular rhythm, but the heart rate is above 100 beats per minute, then we call it sinus tachycardia, as you can see here. While when the heart rate drops below 50, but we have the same pattern P, Q, R, S, T, and we have regular intervals, so in that case, we call it sinus bradycardia. So sinus means regular beats with the presence of P waves. And normal sinus rhythm 50 to 100, sinus tachycardia above 100, and sinus bradycardia is less than 50 beats per minute. So it's very important to know to say when the rhythm is regular or when the rhythm is irregular, in order to be able to diagnose the conditions that the patient have. So here, for example, it's irregular. You can see clearly that the RR interval is the same. So here is the same as here is the same as here. While in the second example, you can see that it's clearly irregular. So here you can see that the RR interval here is different than the RR interval on the second beat. So this is what we call an irregular heartbeat. Okay. So then the third step is to know how to locate the P wave. So we said we calculated the heart rate, and in the second step we see if the rhythm is regular or irregular. Now we should detect the P waves. So the P waves are the impulses that are just before the QRS complex, and we said that the P wave means the atrial depolarization, so the atrial electrical activity or atrial contraction. So here you can see we have clearly P waves, so P waves followed by QRS followed by T, and the rhythm is regular because from here to here, the duration is the same from here to here. So this is a normal sinus rhythm. While on the second example, you can see that the rhythm is irregular. From here to here is different from here to here. And you can see there is no evidence, no clear P wave. So when we don't see a clear P wave, in that case, it's not a sinus rhythm because it's irregular without evidence of clear P waves. So in that case, this is what we call atrial fibrillation. So no evident P waves and irregular intervals between RR complexes. So this is atrial fibrillation, absence of P waves. It's very important. Then after analyzing the P wave, you need to look for the QRS morphology. So the QRS is just after the P wave. So you can see you can have different morphologies. You can have just a pure positive QRS complex, what we call an R complex, an R wave complex, just R, there's no Q, no S waves. R wave is always the first positive wave that you detect on the ECG. And when we have a negative wave after the positive wave, we call it RS. So here is the second one is RS because we have a negative deflection, which is the S wave, and this is the R wave. So R, S. Here is, for example, when we have the first deflection is a negative deflection before a positive, we call it a Q. So here we have a QRS, complete QRS. So Q, here, R here, and here is an S wave. Okay. Sometimes you have a more deep Q wave, so QS, we call it QS because there's just one Q negative wave. And when we see this wave, you need to always think of a patient that had an old myocardial infarction. So the patient that had an infarction before, there will be always traces on the ECG after that. So if you do the ECG after months or years after a myocardial infarction, you can detect a QS complex. This means that we had an old ischemia on the level of the heart. So you can see there's different shapes of the QRS segment. Each shape indicates a different pathology. We'll see that progressively during this lecture. Okay, so after looking on the shape of the QRS, now we need to know if it's a narrow QRS or a wide QRS, so either narrow or broad QRS. So normal QRS width, so the width is from here to here. The width of the QRS should be from 70 to 100 milliseconds. Sometimes we can go up to 120 milliseconds. So we can say between 70 to 110 milliseconds is normal, the width of the QRS complex. Okay. So when we have this width, we can know that the electrical activity is originating in the supraventricular region. So normally from the SA node to the AV node, then to the ventricle. So when we have the narrow QRS complex, we can confirm that this is the normal pathway of electrical activity. But when the QRS become broader, so the QRS become wide, between more than 120 milliseconds, like you see here. So we said each small box is 40 milliseconds. So here it's 40, 40, and 40. So here it's 120 milliseconds. So here it's a broad QRS. And when we see a broad QRS, then we can confirm that the electrical activity is originating from a different pathway. So here it's originating in the ventricles. It's not originating above in the SA node, like we said, in the normal conduction. So here it's originating in the ventricles. That's why the QRS becomes broader. So it's very important to differentiate supraventricular activity from ventricular activity. And you do that by looking on the width of the QRS. So when it's less than 110, it's normal, narrow QRS. When it's above 120, it's a wide QRS originating, the electric activity is originating below the AV node from the ventricular region. So if you look here on this ECG tracing, you can see that this is lead 2. You can see there's a P wave here, followed by QRS, followed by T. Then after that, you can see here this QRS complex is a narrow complex, because if you look closely, it's less than 3 small squares, so less than 120 milliseconds. So this is a normal QRS. While the next one, this QRS is 3 small boxes, so it's 120 milliseconds. So this is a wide QRS. So narrow, here is a narrow, here is a wide. And here it's a narrow and a wide. It's repetitive, so narrow, wide, narrow, and wide. So normal beat followed by abnormal beat, normal beat followed by abnormal beat. And if you look closely, this beat is a bit premature, so it should start here, but it started before. So this is a premature beat, and we call it a premature ventricular beat or premature ectopic beat, PVC. So when we see this pattern, normal followed by a PVC, then normal followed by a PVC, and it repeats itself, we call this ventricular bigeminy. So this is a rhythm with a lot of premature beat originating in the ventricles. We said we should have a wide QRS when it's originating in the ventricle, and we call it here a premature beat because it's coming before expected, and it's followed by a pause. So we have a small pause following each of the premature beats. So this is what we call a ventricular bigeminy rhythm. Other narrow complex rhythm, so we said this, the first one is sinus rhythm. So we have P wave followed by QRS followed by T. It's regular. So regular from here to here. This is a normal sinus rhythm. You can see it's a narrow QRS because here it's originating from the SA node. Same for atrial fibrillation. It's a narrow QRS because also it's originating in the supraventricular area. But here the difference is that we don't have clear P waves. If you look, there's no, we can see small notches here and notches here, but these are fibrillatory waves. They are not clear P wave like you see in the first example. And you can see that the rhythm is irregular. That's why we call it atrial fibrillation. So from here to here is different from here to here. We have irregular beats in that case. Okay, so just focus here on sinus versus atrial fibrillation. Both they have narrow QRS. One is regular, the other is irregular. And in the sinus rhythm, you have P waves. Here you don't have clear P waves in the atrial fibrillation. So we have fibrillatory waves, like small notches that looks like P wave, but they are not truly P waves. We said sometimes we can have wide complex rhythm, so the rhythm is originating below the AV node, so from the ventricle, and we can have a lot of causes. So we can have what we call right bundle branch blocks and left bundle branch blocks. You will take the lecture on the blocks on the next presentation today. but you just here it's an introduction to talk about everything. So we can have a bundle branch block. So the bundle branches are electrical conduction system propagating electricity from the AV node to the ventricles. Sometimes when we have hyperkalemia, so hyperkalemia when we have potassium above 5 and above 6, it can lead to widening of the QRS complexes. Sometimes if we're on medications like tricyclic antidepressants, this can also lead to widening of the QRS complexes or other pathologies, pre-excitation. So these are pathologies that can cause arrhythmias, so Wolff-Parkinson-White syndrome, or if the patient has a pacemaker, the QRS will becomes wider, so above 120 milliseconds because of the presence of the pacemaker. And if we have hypothermia, so drop in temperature, especially when the temperature drops below 34 degrees, the QRS will widen progressively. So here is an example. So here you have a wide QRS. So the QRS starts here and it ends here. So it's around 120 milliseconds. So it's a wide QRS. And in that case, it was a ventricular tachycardia rhythm strip. So here it's a very dangerous condition that we uh, uh, need to act in here in order to revert it to normal sinus rhythm. But here you just need to focus on the widening of the QRS complex because the rhythm is originating in the ventricles. So it's a ventricular tachycardia with wide QRS. You also need to look on the voltage. So sometimes you can see if you look here, it's the wave here, it's an R wave. It's very tall R wave. So when we see this pattern on the ECG, you can see V5 and V6. Here is V5, here is V6. You can see that we have a very tall wave. And when we see this on the ECG, you have to suspect left ventricular hypertrophy. Okay, but you need to know that sometimes, and especially in young patients less than 40 years of age, sometimes you can see this pattern without left ventricular hypertrophy. But always when we see very tall waves, you need to suspect it. And there is a criteria called Sokolov-Lyon criteria. So you can see it here, Sokolov-Lyon criteria. So in this criteria, you look on lead V1 and lead V5 or V6. You measure the amplitude of the QRS in V1. So here it's 16 millimeters. So just you calculate it, it's 16 millimeter in V1. And you use either V5, so here it's V5, here it's V6. You use the tallest one. So here's the tallest one. I think it's V6. So it's 32 millimeters. You add 16 plus 32 if you have a value above 35 millimeters. So here it's a very strong criteria to detect left ventricular hypertrophy. So here in that case, this patient had in fact left ventricular hypertrophy because V1 plus V6, 32 plus 16 is 48, is above 35. So here it's a positive Sokolov-Lyon criteria. And in that case, when you have this positive criteria, you need to do an echocardiogram in order to diagnose left ventricular hypertrophy. So always think of it when you see very tall waves, especially in V5 and V6. Here to the opposite, in this ECG, you have very low amplitude. So very low. If you look, the amplitude is very low. So this is a low amplitude ECG, and in order to diagnose a low amplitude ECG, so you need to look on limb leads. So leads 1, 2, 3, AVF, AVL, and AVR. If the QRS complex is less than 5 millimeters, so it's a positive criteria. So here you can see it's less than 5 millimeters, the QRS. So here is a low amplitude in 1, 2, and 3. These are the limb bleeds, AVR, AVL, and AVF. All of these are low amplitude. And you can look also on precordial leads, but the precordial leads here, they should be less than 10 millimeters. Okay, so here you can see, but it's more clear in the limb leads here. They are clearly it's below 5 millimeter in amplitude. Okay, so when we see this low voltage on the ECG, so we have low voltage ECG, we call it, you have a lot of different differential diagnoses, but you just need to understand. So when we see the low voltage, it means that the distance from the heart to the electrode recording the electrical activity becomes bigger. So the distance from the heart to the electrode is wider. What can cause this? We have a lot of cases. We can have pericardial effusion, for example. We have fluid around the heart. This will increase the distance from the heart to the chest wall or to the electrodes. It can cause this. Patients with COPD, because they have a lot of air that is being entrapped in the lungs, so also the distance becomes wider. Patients with obesity, so always patients that are obese, they tend to have low voltage ECG. Also, in case of patients that are post myocardial infarction, post myocarditis, sometimes we can see it. But the most common causes are obesity and pericardial effusion. So always when you see low voltage ECG, you need to, if the patient is not obese, you need to think about pericardial effusion because it's a dangerous condition because of the fluid accumulating around the heart. So always think of it when we see an ECG like this one. Here is also another condition also related to pericardial effusion. So here you can see that you have different QRS, and each QRS has a different amplitude. So here it's bigger than here, it's bigger than this one. So we have different amplitudes. What we call this electric alternance. So each QRS is having a different amplitude as compared to the previous QRS. And you see this when the heart is moving inside the pericardial fluid. And you see this when we have massive pericardial effusion. So if you look on this chest X-ray, you can see the heart border is very wide. This patient had a massive pericardial effusion, so the heart is moving inside this fluid-filled area, and when the heart moves, the electrode will record the QRS complexes. They will have different amplitudes because of the moving heart. So this is what we call electric alternance, and it's very suggestive of massive pericardial effusion around the heart. We can see it sometimes without pericardial effusion, but also it's a very should have a very high degree of suspicion of pericardial effusion when we see it. Okay, we already talked about P waves. We will not go talk again. We already saw this slide. Just a reminder. We already talked about atrial fibrillation as well. So we said irregular beats without evidence of clear P waves. We can have fibrillatory waves, but these are not true P waves. And now, after all of this discussion, we will learn now how to measure the heart axis. So the cardiac axis, it reflects the combined vectors of depolarizations, okay, produced in different cardiac muscle cells. And it's very important to know how to measure this axis because sometimes a deviation of the axis will give us a clue about a pathology that is present for our patients. You just need to know that when we have a QRS complex with more positive than negative, so R bigger than S, this is R, this is S, you call this a positive QRS because it's more positive than negative, so you just call it positive. Okay? This is important in order to know how to measure the axis. When we have the positive equal to negative, this is what we call an equiphasic axis, so R equal S. And when we have R less than S, so here is R, here is S. So S is more than R, so in that case, negative is more than positive, so you call it a negative QRS. So positive, negative, and equiphasic. And when you look on this one, this figure, you need to memorize it. It's very important because when you look at it, it will be very simple to know the axis, okay? So when on the ECG you have, sorry, we'll look here. So here is this as an example of a normal heart axis, okay? So you always look on lead 1 and on lead AVF, okay? When lead 1, here lead 1, we have RS, but R is bigger than S. So R bigger than S. So this is a positive QRS. And AVF also is a positive QRS because you just have a positive deflection. Then you look on this figure here. So when 1 is positive, so we're here, and AVF is positive, so we're also here on this direction. So you can see here the direction of the vector. The positive is here, the negative is here, the positive is here for AVF, and the negative is here. So when both are positive, so if we have two vectors, the vector that will result from these two will be in this area. So it will be in the normal axis region. So one is positive and AVF is positive. So this is a normal heart axis. But when we have one that is negative, so we're here on the other side, and AVF is positive, so it's this is the case here. So you can see one is negative and AVF is positive. So when we have this, one is negative here, look on this one, and AVF is positive. So this is the resulting vector will be here. So this is the area of the right axis deviation. And when we see right axis deviation, you always need to think of pathologies involving the right ventricle. So for example, if a patient has pulmonary hypertension, it will impact the right ventricle. So respiratory diseases as well will give us a right axis. Pathologies of the right ventricle, pulmonary embolism, all of these conditions can give us right axis deviation. Well, if you look on this ECG here, we said we always look on 1 and AVF to know the axis. So here 1 is positive and AVF is negative. If you look here, it's negative AVF. So we're in this area. So 1 positive and AVF negative, we can be in this area. But if you look closely, this area contains also a small portion when we have a normal axis, so the one on in purple. So just when we have one positive and AVF negative, in that case, you always need to look on lead 2. In all other conditions, you don't look at lead 2. Just you look at lead 2 when one is positive and AVF is negative. So in this example, lead 2 is also negative. So lead 2 is here. So the negative lead 2 should be something around here. And if you combine one positive to AVF negative and 2 negative, the resultant will be here on the green portion. So we will have a left axis deviation here. Okay, so it's a bit complicated, but here is a table that resumes everything. So we said we look on lead 1 and on lead AVF, okay? So when 1 is positive and AVF is positive, this is a normal axis. When 1 is negative and AVF is positive, you just can say it's a right axis deviation, and here you need to look on pathologies of the right ventricle, pathologies of the lungs, respiratory, pulmonary hypertension, pulmonary embolism. Okay, and when we have positive lead 1 and negative AVF, we always need to look on lead 2. So if lead 2 is negative, like here, so positive, negative, negative, in that case, it's a pathologic left axis deviation. And here it indicates that there's something going on in the left ventricular wall. So it's very important to know how to measure the axis. So always draw this figure, and it will become very easy to know what the axis is. Okay. So now we'll go deeper and analyze the P waves alone. So the P waves should always be positive. So they should always be positive in all leads except in AVR. So in AVR, they will look negative. So like this. Okay. So always should be positive, mainly in lead 1 and 2, and negative in AVR. And sometimes it's negative also in lead V1. And the duration of the P wave, so the width of the P waves, it should be less than 120 milliseconds, so less than 3 small squares, because we said in the beginning that each small square is 40 milliseconds. So the duration of the P wave should be less than that. We will see if it becomes wider, it indicates that we have the pathologies of the atria. So we'll see it in the next slide as well. Also, the amplitude, so the amplitude should be less than 2.5 millimeters when we see on the limb leads, and less than 1.5 millimeters in the precordial leads. This is normal. So the duration should be less than 120 milliseconds, so less than 3 small squares horizontally, and vertically, so the amplitude should be less than 2.5 millimeter in limb leads, and less than 1.5 millimeter in precordial leads. And it's best to look to analyze the P wave in inferior leads, so in lead 2, 3, and AVF, and in lead V1. These are the best leads to analyze the P wave. If you look here on this example, so this is a P wave. you can see that this first 1/3 of the P wave, so from here to here, this is the right atrial depolarization. And the rest is left atrial depolarization, and in between, it's the region that combines both. But when you look on the ECG surface ECG, you can't see both. You just see one P wave. You can't differentiate from left atrial and right atrium because here right atrium is a bit before left atrium, but you can't see it on the surface ECG because it's very small. But you need to know that it contains two components. So right atrium, especially in the beginning, is first 1/3, and left atrium, second 1/3, and in the middle, it's a combination of both. But sometimes it becomes evident. So when you have, for example, right atrial enlargement, like in this case, so here it's a right atrial enlargement, you can see when you have right atrial enlargement, the amplitude of the QRS will become a lot bigger. So we said the normal amplitude should be less than 2.5 millimeter. Here it's very clearly 5 millimeters. So when we have right atrial enlargement, the amplitude of the QRS complex will become bigger. So it will become above 2.5. While when we have left atrial enlargement, here the amplitude stays the same, but the duration will become wider. So it become above 120 milliseconds, and sometimes it can become biphasic. So you can see this biphasic. So it will become wider in duration and to become biphasic, but the amplitude usually it remains normal. So right atrial enlargement, we said the amplitude will go up. Left atrial enlargement, the duration will go up, and you can see biphasic P waves. It's very important. So to differentiate between these two conditions, right atrial enlargement is increasing amplitude, left atrial enlargement is biphasic and increasing duration. And it's always better to look on lead 2, 3, and AVF for these, and lead V1 also. You will see the clearest P waves in these leads. Okay. Sometimes you can see we said the P wave should always be positive, but here we can see clearly that the P waves have become negative. So when we see negative P waves, in that case, uh, so here the origin is not originating from the SA node, it's originating from the junction, so it's from the AV junction. You will have a lecture about junction rhythms today also, but here you just need to understand. So when the P waves is negative in the leads, that the P waves should be positive. So in that case, you can diagnose junction rhythm. It's be originating from the AV node or from below. Sometimes you can have variable P wave morphology. This is very important. If you look on this ECG, this is a P wave. This is another P wave. This is another P wave here. This is another P wave here, another P wave here. You can see that clearly each P wave have a different morphology. So this one is different than this one, is different than this one, different than this one, different than this one. And here also the rhythm is irregular. So the duration from here to here is different than from the duration from here to here. Is different also from the duration from here to here. So this is an irregular rhythm. But we have P waves. It's not like atrial fibrillation. Here we have P waves, but these P waves have different morphologies. So when we see this irregular beat with different P wave morphologies, so you should have 3 or more P wave morphologies. When we see this with irregular beats, then you can diagnose a condition called multifocal atrial tachycardia. So this condition is always associated with hypoxia. So you can see this in hypoxic patients. So patients that have low oxygen saturation, say sometimes present with irregular heart rhythms with P waves, but P waves are different in morphology. So 3 or more different. Here, if you can see, we have 5 different P wave morphologies. So here the treatment is just to give oxygen. There is no need to give antiarrhythmic medications. Here you just need to give oxygen therapy to reverse it. Okay, so correct the underlying cause always. Q waves, so we said the Q waves are the first negative waves. So you can see here we have a small Q wave here. This is a Q wave, a small Q wave. This is a physiologic Q wave. So this is a normal Q wave. You can see it in lead 1 AVL, V5, and V6. That indicates We call it a septal Q wave because it's originating from the septal area, but this is a normal one. When the Q wave, we say the Q wave is abnormal, so we call it a significant Q wave when the Q wave becomes uh, it becomes wider. So the Q waves become above 30 milliseconds, and when it also the amplitude of the Q waves goes up as well. So when it becomes more than 1/3 of the whole complex, we also call it significant. So to be significant, it has to be wide above 30 milliseconds. So here 30 milliseconds, and it should be bigger than 1/3 of the total QRS complex. So this is the Q wave here, and this is an R wave. So here we have a QR, but the Q is more than 1/3 of the QR, of the whole QR complex, okay? And it's wide, it's above 30 milliseconds. So this is a significant Q wave. And when you see this, you should always suspect a previous myocardial infarction. So the patient that had a myocardial infarction in the past, okay? So we said it should be wide, 30 or above 40 or above 30. Some references say 40, some references say 30, and it should always be deep and more than 1/3 of the total QRS complex. And it's best seen in lead V1 to V3 also. So the differential diagnosis is old myocardial infarction, as we said. Sometimes we can have hypertrophic cardiomyopathy, so we said we can have very tall waves, but sometimes we can also see Q waves in hypertrophic heart. Sometimes if the leads are misplaced, you can always see you can see always Q waves when the leads are placed incorrectly. So we need to always make sure when we see large Q wave to ask the patient if he previously had a myocardial infarction, and you need to check also if the leads are placed correctly before proceeding. Okay. Can someone tell me here where do we see pathological Q waves on which leads? Please write in the chat if someone knows. Please tell me where do you see pathologic Q waves in this electrode, in this ECG, please. Okay, so this is a sinus rhythm because you have P waves, QRS, P wave QRS, and it's regular. So it's regular from here to here, from here to here, is the same duration. If you look closely on inferior leads, you can see here, this is a deep Q wave. So it's a P wave that is above 40 milliseconds in duration. So it's above 40 milliseconds, above one big square. And it's deep because it's bigger than 1/3 of the total QRS complex. So this is a pathologic Q wave. And you can see here also we have ST segment elevation. So this is a case of myocardial infarction associated with the presence of pathologic Q waves. This is a myocardial infarction, but it's not very recent. It's 2 to 3 days ago, for example. It's not acute myocardial infarction because here we have the development of Q waves. Okay, so T wave also, the T wave we said it's ventricular repolarization. It's the wave following the QRS. So usually it's always positive except in AVR and V1 where when the T wave should be negative. So in all leads, the T wave should be positive except in AVR and V1 it should be a negative. And when we see T wave abnormalities, also you can have peak T. I will show you examples. So we can have either peak T wave or acute T waves, so very big and tall T waves. Sometimes you can see biphasic T waves or flat T wave or inverted T wave. So inverted T wave, when we see inverted T wave, you always need to suspect ischemia. So for example, an artery that is narrowed or occluded. So you always think of it. Here is an example of very tall Q waves. So we call these peak T waves. You see them, they are typical with hyperkalemia. They are a bit asymmetric. So these are very typical of hyperkalemia. So asymmetric, when you do the midline here it's a bit bigger than here. So asymmetric tall P waves are seen in cases of hyperkalemia. While here we can see symmetric, also asymmetric hyperacute T waves. So these are seen in myocardial infarction as well. So you can see the T wave is very big. It's asymmetric here. Sorry, here it's symmetric, and here it's asymmetric in myocardial infarction. But you can see it's a very tall T wave. So when you see this, you need to suspect myocardial infarction. That is, you need to do a coronary angiogram and order cardiac enzymes in order to see the vessels. So inverted T wave, as I told you, so inverted T wave, you just can see it in lead AVR and V1 normally. But when you see inverted T wave in other leads, so like here in inferior leads, 2, 3, and AVF, so this is pathological. And when you see this, you need to think of an ischemia. So here is the most common cause, so myocardial ischemia. But you need to know that in pediatric patients or young patients, you can see persisting of this pattern, so negative T wave and inferior leads. This can be considered normal in young patients. We'll skip P wave. It's not very important. I just want to show you also what we call an Osborne wave. So this wave, you can see it here. So we have the QRS here. We have the P. Then we have sorry, this is the P. Then you have the QRS here, and then you have the T here. Between the QRS and T, you can see a small notch just after the QRS complex. This is what we call a J wave or Osborne wave. This wave is very typical for conditions of hypothermia. So when the body temperature drops, mainly below 30 degrees Celsius, so when we see a drop in body temperature, you will see on the surface ECG the development of an Osborne wave. For example, sometimes a patient comes to the emergency department due to a loss of consciousness. They find him on the street and he's very cold. You do an ECG, you find this Osborne wave, so you confirm that this patient have a very profound hypothermia, so less than 30 degrees Celsius, because sometimes we can't measure it with the temperature when it's very low. So when you see this, you confirm it's a severe hypothermia. Okay, so here it's a temperature of 28 degrees in a patient. You can see here is a very clear Osborne wave being developed here. This is an Osborne wave. So Osborne wave in all leads, this is hypothermia. Okay. Now we will talk a bit about the PR interval. So the PR interval is from the beginning of the P wave till the beginning of the QRS complex. So this is what we call from here to here. It's the PR interval. It reflects the atrial depolarization and the electrical conduction from the SA node to the atria, then to the AV node. So this segment will give us an idea what's going on in the atrial contraction and in the electrical conduction as well. So normally this interval should be between 120 to 200 milliseconds. So it should be between 3 small boxes and 5 small boxes. So between 3 to 5, because each small box we said is 40 milliseconds. So it should be between 3 to 5. And when we see its interval goes up to above 200 milliseconds, so this is associated with heart blocks. So also there's another session today about heart blocks. I will not go into details now. You just need to know that when the PR becomes wider, above 200, so in that case, we have a heart block. And when the PR becomes shorter, so less than 120 milliseconds, so this means also a pre-excitation or a junctional rhythm. So here, when you have pre-excitation, there is a risk of developing arrhythmias also, like the case of Wolff Parkinson White. We have a short PR interval. So always the PR reflects the atrial depolarization and the electrical conduction from the SA node to the atria to the AV node. So when it becomes wider, so above 200 milliseconds, it means we have a heart block. And when it becomes narrower, it means that we have pre-excitation or we have an AV nodal rhythm, so junctional rhythm. We will see all of this in details later on today. So here you can see other pathologies involving the PR interval. So here the duration of the PR interval is not wide. It's around 4 small boxes. So here it's around 160 milliseconds. So it's normal between 120 to 200. But you can see that here is the isoelectric line. Here the PR segment is depressed. So it's below this line. And here the PR segment, it's above this blue line. So here we have PR depression and PR elevation. And you can see this condition in acute pericarditis. So when a patient presents with chest pain typical of acute pericarditis, and you see this on the ECG, you need to think of acute pericarditis. So PR segment depression and PR segment elevation. And here the PR segment is normal. It's 160 milliseconds, so it's between 120 to 200. So it's normal in width, but it's deviated. Okay. Now we'll move, just talk a few slides about the QT interval. So the QT interval is from the start of the QRS segment till the end of the period. So start to end here, okay? All of this is the QT segment, okay? This will reflect the ventricular depolarization and repolarization, so the ventricular contraction and relaxation at the same time. It gives us an idea of what's going on in the ventricle during the relaxation and during the contraction. So it's very important to measure this QT interval. So there is a lot of tool to measure it, but also you need to use this formula. So we have a formula, what we call Bazit formula. So you measure it on the ECG, you count the small boxes, you will have a QT interval measure here in milliseconds. But sometimes you need to adjust it based on the heart rate, because when the heart becomes faster, the QT segment will be different. So this formula gives you an idea about the QTC. So this is the corrected QT segment. So you need to use this formula. And normally the QT interval should be less than 450 milliseconds, so in general. But when it becomes above 450 in men, or 450 in women and 460 in men, so in that case we can call it a prolonged QT. And when the QT becomes above 500, so this is a very high risk to develop arrhythmias, like the case of torsade de pointe. So this is a polymorphic ventricular tachycardia. You can see here the QT is prolonged. So here is the QT segment, it's prolonged. And progressively it's become wider. And after that, you can see the initiation of a polymorphic ventricular tachycardia as a result of a long QT segment. And this is a very dangerous condition. So you need to act rapidly here. So what are the causes? So we can have a lot of electrolyte abnormalities. So low potassium, low magnesium, low calcium, low temperature as well. So low temperature is associated with Osborne waves and also with the development of a prolonged QT segment. Myocardial ischemia, also increased intracranial pressure. So if a patient has bleeding in the brain, sometimes the QT segment on the ECG will become bigger. And some medications like antidepressants, antipsychotics, and the antiarrhythmics. A lot of antiarrhythmics can prolong the QT, like amiodarone, which is a class 3 antiarrhythmic, so it can prolong the QT interval. And when we have a long QT interval, so this can precipitate a condition like torsade de pointe. We just need to know that we have also a congenital long QT, so the patient is born with a long QT. We will not talk about the details, but you just need to know that it exists to have it congenitally, so at birth. Okay, so here is an example. If you look closely here, I will show you how to know if the QT is prolonged without measuring it. So the QT segment is from here, the start of the QRS, till the end of the T wave. Here, clearly it's prolonged, but sometimes if you're not sure, you draw the midline uh, between two complexes. So for example, if you take this one and this one, the midline is here, around here. Okay, when the T waves extends beyond this midline, so for sure here the QT segment is prolonged because it's extending after this midline. So without calculation, you just can confirm that this QT segment is prolonged, and you need to eliminate all of these conditions responsible for the prolongation of the QT segment when you see an ECG like this one. So you just need to rule them out one by one. Sometimes you can have a short QT interval, so the opposite here, shortening of the QT interval here, it's 260 milliseconds. You can see it clearly that the QT interval is very short. Here it's most of the time associated with hypercalcemia. So we said hypocalcemia can cause prolongation of the QT, while hypercalcemia to the opposite will cause shortening of the QT. It can also be due to congenital, so at birth they have it, but most of the time we see it with hypercalcemia. Okay, so we need to correct the calcium here, and by correcting the calcium, the QT segment will normalize systematically. The last thing that we'll talk about in the ECG section is the ST segment. So the ST segment is very important. Why it's very important? Because we said it's the region of ventricular depolarization and repolarization. And you always need to look for ST segment elevation or ST segment depression because this is a very important tool to diagnose myocardial infarction. So I will show you a few examples. So all of these are example of ST segment elevation. So here is the isoelectric line. You can see that the ST segment is deviated upwards. So all of these are shapes of ST segment elevation. You can see here the midline. And here is the elevation of the ST segment here also. So all of these should give you a high suspicion to diagnose myocardial infarction, ST elevation myocardial infarction. And when you see this on the ECG, you should send the patient directly to the catheterization lab, and you should call the interventional cardiologist in order to open the blocked artery. So for sure here, most of the times you will find an occluded vessel, an occluded coronary artery. Other causes of ST segment elevation. So we said we have acute myocardial infarction, most common cause. We can have coronary vasospasm, pericarditis. Also, will give you a diffuse ST elevation in all leads. So these are the most three common causes. So myocardial infarctions, ST elevation, coronary vasospasm, and pericarditis. These are the three most important and most frequent causes. Anyone wants to tell me here where is the ST elevation on what lead? Please, if someone knows, you can write it on the chat. Any idea? Yeah. So here, if you look closely on lead V2, V2, V3, V4, you can see that the ST segment is deviated up. So when we see this pattern, you can diagnose acute myocardial infarction or ST segment elevation myocardial infarction. So in fact, this patient had an occluded left anterior descending artery. So his coronary artery was occluded. So he was sent directly to the catheterization lab, and his coronary was, and we put a stent inside his coronary in order to restore the blood flow. And if you look on this one, we said V1, V2, V3, V4 is anterior wall, and this anterior wall, we have the changes on this ECG in this anterior wall, and this means the problem here is in the left anterior descending artery. So in fact, the ECG gave us an idea also about which artery is occluded, and in fact, it was the left anterior descending artery as well. You can see also there is a prolongation of the PR interval. So the PR interval here is above 200 milliseconds. So we have also we have first degree, we have AV block also associated with this myocardial infarction. Other ischemic changes. So sometimes we have ischemia, but we can have a normal ECG. Not always you will see this pattern. Q waves, we said T wave inversion or T wave flattening is also suggestive of ischemia, or new onset positive serial T wave. So if a patient has a negative T wave and suddenly it becomes positive, so it's also an ischemic sign. ST segment depression and ST segment elevation, these are the two most common important indication to diagnose acute myocardial infarction on the ECG. Okay. I just wanted to show you this last ECG before we finish our first session. So this is a patient. I show you. We already talked about this. So if you look on this lead, you can see the rhythm is a bit irregular. You can see the duration from here to here, for example, is different from the duration from here to here. So it's irregular. But you have P waves. You have different P waves. Each P wave is different. So we have different P wave morphology with irregular rate and fast heart rate. So in that case, we call it multifocal atrial tachycardia. And in this condition is due to hypoxia. We said it's due to lung disease when the oxygen drops. So here the treatment is to give oxygen to the patient in order to treat it. Okay, so if someone is interested, there's a very nice website called Life in the Fast Lane. This website, you can see a lot of ECG inside, a lot of ECG interpretation for beginners and for advanced also. You can see everything inside. And that was my first lecture. If you have any question, you can ask in the chat box. Okay, so we'll just take 2 minutes break and I will start sharing my second presentation in 2 minutes, okay? Can you see the slides of the next presentation? Please type yes in the chat if you're seeing them. Okay, great. So our second lecture with me will be about the management of patients with altered hemodynamics. So we talk about critical patients when they present to the emergency department, and we will start by giving cases. So we'll discuss cases here. The first case is a patient of 70 years old. He is 70. He has a past history of coronary artery disease. So the patient has a lot of stents implemented in his coronaries, hypertension, diabetes, and chronic kidney disease. So you can see he has a lot of risk factors to develop cardiac conditions. He presented to the emergency department uh, lower limbs edema associated with acute onset of dyspnea. So there is lower limbs edema with new onset dyspnea that was not present before in a cardiac patient. Okay. So if you look on his vital signs, he was very tachycardic. So the heart rate was 170 beats per minute. We said it should be between 50 to 100. So he is very tachycardic, and the blood pressure is low. So the blood pressure here is 70 to 50. So he is hypotensive and tachycardic, and he's a bit hypoxic as well. The saturation is 88%, and he had a normal temperature. There is no fever. Okay, so on the physical examination, the patient had irregular heartbeats. So on the cardiac auscultation, the rhythm was irregular. He had no murmurs, and on the lung auscultation, he had bilateral lung crackles, and his lower limbs he had edema, significant edema in his lower limbs. So in front of a patient that is tachycardic with irregular beats and hypotensive. So this patient is unstable because when you see the definition of unstable patient is either low blood pressure, either altered mental status, or either very fast heart rates with chest pain, for example. So mainly it's hypotension and altered mental status. So here we have hypotension, very significant hypotension with very fast heart rates. This is our lower limb spitting edema. So this is suggestive of cardiac condition. So of volume overload. You can see when we press on the limb will not will, the edema will. You will see we have significant edema in that case, so fluid accumulation. And if you look on the ECG, so we already explained the ECG on in the first session, but briefly, this is an irregular rhythm. So we have irregularity here. Irregularity is the duration is not the same, and we don't have clear P waves. So this is atrial fibrillation ECG. Okay, with a fast rate. So we have AFib, atrial fibrillation, with a fast heart rate, so irregular beats without P waves, and a fast heart rate, so tachycardic and hypotensive. So here we are in front of an unstable case, hypotension with tachycardia and signs of decompensation, low oxygen saturation. So it's a complicated case. This is the chest X-ray. So if you look on this chest X-ray, you can see this is the heart border. It's not very enlarged, but you can see we have a lot of opacities here and here. So when you see this, this is an acute pulmonary edema X-ray. So this patient had, in fact, acute pulmonary edema because you can see the fluids are accumulating in the lungs and the lower limbs. So the heart muscle is failing due to the tachycardia. So when the heart rate is 170, 180 with a low blood pressure, so here for sure we're in the condition of decompensated heart failure. Okay. So here we are in front of a tachycardia in a patient that is hemodynamically unstable. So what to do next? What do you think we should do here? The heart rate is 170 and the blood pressure is low. What do you think we should do in order to treat this patient? The best next step. Any idea? Okay, so when we have an unstable atrial fibrillation or an unstable tachycardia, with hypotension. So the first thing that we should do is to attach the patient to the defibrillator to do the cardioversion. So here you can see this is the patient. He has an irregular rhythm with very fast heart rate. You attach the cardioversion patches and you link them to the cardioverter. This is a real-life example of a cardioverter machine. The most important button here is to select energy, so how much energy the shock you want to administer should be, how many joules. And there's a button below to know if the rhythm is synchronized, yes or no. So in cases of like this one, where we have pulse and when there is where we have clear QRS complexes, we should put it always on synchronized mode. So it's very important to switch this and put it on synchronized mode. And how to prepare the procedure. So we should always have an anesthesiologist with us, either a registered nurse anesthesiologist or a medical doctor. And you need to apply the electrodes. So usually you put 3 electrodes and you link them to the defibrillator or cardiac monitor. And then you put the pads and you connect them to the defibrillator machine. Okay, so here you give the sedation, and once the anesthesiologist give you the green light in order to shock, you can shock the patient. So usually when you have a narrow complex tachycardia, you can start with low energy shocks. You can start with 70, then you can go up to 120 if it's still refractory, and you can go up to 200. Okay, so then you sedate the patient before administering the shock, and then you move from the bed, and you also cut the oxygen at the moment of the shock. And when you all is clear, you can shock the patient, and usually the patient should go back to normal sinus rhythm after the shock. And you can, if unsuccessful, you can repeat, you give higher energy. And usually we do 3 attempts. three attempts, and then we stop. But depends on the patient. So sometimes we can have complications with shocks. When you shock the patient, you can have complications. So the patient can go to asystole or bradycardia after the shocks. So in that case, we need to put a pacing pad as well. So we need to accelerate his heart rate. Sometimes we have bradycardia. Sometimes we can have ventricular tachycardia. So it's a very dangerous condition. So here we need to repeat the shock in order to revert it as well. And sometimes the patient can go to pulseless, so he can go into cardiac arrest, VTAC or VFib. So this is an ACLS algorithm here. So we can have a complication of cardiac arrest after a cardioversion. So here is a nice diagram from ACLS medical training. You can see that when we have unstable supraventricular tachycardia, so first you can try to do vagal maneuvers. If it's unsuccessful or the patient is very unstable, you move directly to here. So the patient is not unstable, it means he has hypotension and he has signs of shock and he has altered mental status. So here directly you go to synchronized cardioversion. If the patient is stable, it means that he is tachycardic, but he has no hypotension, he has no signs of shock, and he has no decrease in mental status. In that case, you can try to give medical therapy. So in case of atrial fibrillation, you can give, for example, amiodarone. In case of regular supraventricular tachycardia, you can give adenosine. But you just need to know that when he is unstable, which is the topic of today, you go directly to synchronized cardioversion and you give him cardiac shocks. So it depends which energy you start. So to summarize it, so when the QRS is narrow and regular, so QRS is narrow, so it means less than 120 milliseconds, so less than 3 small square. You can start with 50 to 100 joules and you can go up progressively as if the arrhythmia persists. If the QRS is narrow and irregular, you can start by 120 joule and you can go up to 200 joules. When the QRS is wide and regular, you start with usually with 100 joules. And when the QRS is wide and irregular, in that case, you're in a case of ventricular fibrillation. So here, the cardioversion should be unsynchronized. So we call it defibrillation, unsynchronized cardioversion. Okay. So this patient, our patient that we already discussed, so that came with rapid atrial fibrillation. This patient, you can see, had very, very frequent episode of ventricular tachycardia. So all of these are ventricular tachycardia. You can see at night from midnight till morning, 9 a.m. in the morning, the patient had multiple episodes of ventricular tachycardia recorded on the telemetry. So this is what we call ventricular tachycardia storm or electric storm because the ventricular tachycardia is not stopping. So the patient is still having episode of ventricular tachycardia without responding to medical therapy. Okay, so when we see ventricular storm, same. First of thing you should do is to see if this patient is stable or unstable. So if the patient is unstable, directly you should you should shock him. So we should do the cardioversion or the defibrillation. It's the class 1 recommendation. But when the patient is stable, for example, like this patient, he was stable when he had the ventricular tachycardia. So in that case, to stop the ventricular storm, you need to sedate the patient and you need to intubate him in order to stop the autonomic nervous system from acting on his heart. So always the most important step is if the patient is hemodynamically stable or not. If he is not stable, you shock him. If he's stable, you have time, you can sedate him, and you can see if this arrhythmia will stop or not. So it depends on hemodynamically stable, yes or no. So hemodynamically stable means blood pressure. So blood pressure, shock, sign of shock, and mental status. So these three things are criteria to know if the patient is stable or unstable. This same patient, so he was intubated, he was sedated, he was put on medical therapy, but then he develops this bizarre rhythm, which is here you have irregular rhythm, you don't have a clear morphology of QRS, each one is different, so this is ventricular fibrillation. So the patient moved from atrial fibrillation in the beginning to ventricular tachycardia, to ventricular storm, electrical storm, and then to ventricular fibrillation. So we said when we have ventricular fibrillation, this means we are in a cardiac arrest situation. So here you need to give him a non-synchronized cardioversion or a defibrillation in order to reverse this to sinus rhythm. So the patient got complicated more and more, and you can see here he had he has no electrical activity, so he is now in asystole. So you can see here is there is no electrical activity going on. So here we're in a cardiac arrest situation. So here we should start doing CPR. There is no need to shock him because asystole is a non-shockable rhythm. So here we just need to do CPR and give epinephrine in order to treat this cardiac arrest situation. So this is a very nice algorithm from the American Heart Association to tell us how to proceed when we have, for example, asystole, like our case. So here is asystole. So when we have asystole, we need to do CPR every 2 minutes. We do the first cycle. Then after 2 minutes, we check the pulse, we assess the rhythm. If the patient keeps going in asystole, we continue another cycle of CPR. And you should give epinephrine every 3 to 5 minutes. So usually I give it every 3 minutes. And every 2 minutes, we do a cycle of CPR. Then we give epinephrine on the third minute. And we keep on going until we recover a shockable rhythm or until we recover a sinus rhythm. Okay. So we talked, our first case was about a case of unstable arrhythmia. So the patient had AFib, then he had ventricular tachycardia, then electrical ventricular storm, then he went to ventricular fibrillation and asystole. So it's a case that we see frequently in the hospital. So we need to know how to act when we face patients with altered hemodynamics. We move now to the second case, which is a 51-year-old male patient. So 51, he's relatively young. He is also diabetic with history of coronary artery disease. He has 3 stents in the past. He has a history also of heart failure with reduced ejection fraction. So his heart is not pumping blood as expected. He presented also to this from complaining of dyspnea and lower limbs edema and orthopnea. So orthopnea is the sensation of dyspnea, shortness of breath when the patient sleeps at night. So when he sleeps in a supine position, the patient will not be able to take a deep to have a normal respiration. So he will tend to wake him up from sleep. It's due to heart failure. And also the patient has a drop in urine output. So in the last 48 hours, he noted that the urine output also has dropped. And when we measure his vital signs, you can see the heart rate is a bit tachycardic, so above 100. He is also hypotensive, so he is unstable. Saturation is 92, a bit low. He's afebrile. So here the most important part is hypotension in a patient that is oliguric, so low urine output, and in a patient with a history of heart failure. So here we should think of decompensated heart failure or cardiogenic shock, because you have hypotension with low urine output and lower limbs edema, signs of heart failure in a cardiac patient. So same as the first patient, you can see we have pitting edema, so we have fluid accumulating in the lower limbs. This is a sign of heart failure. Just as his chest X-ray, you can see we have the heart is enlarged. So when we say the heart is enlarged, we measure the heart diameter and we measure the thoracic wall diameter. When the heart diameter is bigger than half of the thoracic wall diameter, in that case, we say we have cardiomegaly. And we have also here a pleural effusion. You don't see the costophrenic angle here, so we have fluid accumulating here, and we have fluid here in the hilar space. So this is also a case of acute pulmonary edema. So we have fluids everywhere in the lungs, in the lower limbs. So this patient is decompensating his heart failure. So now this is his echo. So I will show you a video. So you can see this is the left atrium here. This is the right atrium. This is the left ventricle. This is the sorry. So we have, I'll show you the pointer. This is the left ventricle. This is the left atrium, right atrium, and right ventricle. Okay. So you can see that its left ventricle is not contracting well. So this patient is in a condition of heart failure. So we diagnosed this patient by acute decompensated heart failure, and we started him on diuretics, so furosemide 250 milligram IVSP. And because he was hypotensive, we add also an inotrope. So we add dobutamine 5 gamma per hour. So dobutamine is a medication that will increase the heart contractility. And by increasing the heart contractility, we're increasing the blood pressure as well, because the blood is more now pumping to the peripheral organs. So you just can't put furosemide alone, because if you put furosemide alone in a patient that is hypotensive, sometimes the blood pressure goes up a bit, but you need to put an inotrope with it in order to avoid further hypotension, especially at the start of the therapy. So we need to put both together, furosemide and dobutamine. And for this patient, when we put these two medications, the urine output for him has improved. So now he's having 0.5 milliliter per kilogram per hour. So if the patient is 80 kilograms, so he's having 40 milliliter per hour, so it's better. The congestion had decreased, and we were able to stop the inotrope, dobutamine, in 48 hours. And later on, we also stopped the IV furosemide, and we switched him to Peros. So we put him on tablets, and his urine function also kept on improving. So this patient now, well, he was ready to be discharged 7 days after his admission. So it's very important to initiate the therapy early on, and to monitor the therapy based on the urine output. Okay. So here is a nice workup from the European Society of Cardiology. So the diagnostic workup for acute heart failure. I just want to mention a few things here. So for sure, every patient that comes as a ED with these symptoms, you should do an electrocardiogram to diagnose myocardial infarction. Sometimes the myocardial infarction can cause this condition of acute heart failure. Pulse oximetry to see if the patient is hypoxic because of his pulmonary edema, because of the fluid in his lungs. Echo, because same, I showed you an echo for our patients to see if he has heart failure, yes or no. So chest X-ray also to see acute pulmonary edema, lung ultrasound also to diagnose lung congestion. There's a very important test that we do, and especially in the emergency department, when we have a patient presenting for dyspnea, and we're not sure if this dyspnea is from heart origin or from respiratory origin. So we do the test, which is the natriuretic peptide, so the BNP or the NT-proBNP. So this peptide is secreted in response to atrial and ventricular stretch. So in case of heart failure, the NT-proBNP should be high. So the NT-proBNP above 300 it goes with heart failure. But when the NT-proBNP is less than 300, here is the category of patients that we should focus on when the NT-proBNP is negative. So here we can exclude heart failure. So here, when we have negative NT-proBNP, we exclude it completely. We don't have heart failure. But when the NT-proBNP is above 300, we can have heart failure, but we can also have other conditions causing elevation of NT-proBNP. So the negative NT-proBNP is more important to us, because we can rule out heart failure here. We can confirm we don't have heart failure, but a high NT-proBNP can be caused by heart failure, or can be also associated with other conditions. So here is the most important one, the negative pro-BNP, this one. Okay. So all of these tests, so we said we should do when the patient comes to the emergency department with unstable heart failure. So we said we do the ECG. It's recommended to exclude acute coronary syndrome on the ECG. Also, echocardiography is recommended. It's to diagnose also heart failure. It's a major diagnostic tool for heart failure. NT-proBNP, as we said, is also recommended because it has high negative predictive value. So if NT-proBNP is negative, we don't have heart failure, as we said. Also, serum troponin is very important to measure it. It's recommended to exclude acute coronary syndrome as well. And serum creatinine, we should always measure it because these patients they tend to have acute kidney injury because of the low blood flow reaching the kidney. So they tend to have acute kidney injury. Okay. So when we have a patient with acute decompensated heart failure, so we have congestion and fluid overload. So we have signs of hypoperfusion. If we have signs of hypoperfusion, like the case I showed you, so hypotension, decreased urine output, so these are signs of hypoperfusion. So in that case, we should start a loop diuretic with an inotrope, so with dobutamine, not just a loop diuretic alone. But if we don't have a signs of hypoperfusion, so the blood pressure is normal, the urine output is normal, the patient is stable, then we can just start him on loop diuretics without inotropes. Okay. Uh, this is how we should do when we see a patient like this one in the emergency department. So, for example, some patients like this one, he was on furosemide at home, so he was on a loop diuretic at home. So if the patient, yes, was on a loop diuretic at home, we should switch him to IV. So the dose of the IV should be 1 to 2 times the daily per os dose, so oral dose. So for example, if the patient is on a 40 milligram oral dose at home, when we want to put him on an IV dose, we should put him on an 80 milligram IV. So it's the double the oral dose. If the patient was not on oral furosemide, then in that case, we can start him on a low dose of IV, so 20 to 40 milligram IV, and after 6 hours. So after 6 hours, we need to check the urine output. It should be above 100 to 150 milliliter per hour. Okay. If we don't reach this target of urine output after 6 hours, then we need to double the IV dose that we used initially. So if, for example, we gave him 80, in that case, we need to double the dose. So we go to 160 or 250, you need to increase. And you keep on monitoring the urine output until we reach a urine output goal of 100 to 150 milliliter per hour. And then in that case, we can be satisfied and we can start to taper down the diuretic dose. Okay, so this is how you should use the doses of diuretics. So depends if the patient is already on a diuretic, oral diuretic at home, or if he's not. If he's already on diuretic at home, you put him on an IV dose that is double the home oral dose, and after 6 hours, you should have a urine output of above 100 milliliter per hour. If not, you can double also the IV dose until you reach a urine output of more than 100 to 150 milliliter per hour. So sometimes we said when the patient has hypotension, he's unstable, he's hemodynamically unstable, you need to put inotropes. So the most important inotrope we use is dobutamine. You can use it at a rate of 2 to 20 microgram per kilogram per minute. So dobutamine is a beta agonist, so it acts on beta receptor in the cardiac cells. So when this medication acts on this receptor, the cardiac myocardium will contract in a better way. So that the blood pressure will improve, the circulation will improve, the congestion will decrease, the urine output will improve. So it's very important medications that we can use. We can have also the dopamine, milrinone as well, but the most widely used inotrope in case of decompensated heart failure and unstable heart failure is dobutamine. So inotropes, they are necessary to treat patients with either low cardiac output and hypotension, and patients that have LV systolic dysfunction, low cardiac output, low blood pressure due to heart failure. Here we're talking about heart failure, not any hypotension. We should put it on dobutamine. We're talking about hypotension associated with congestive heart failure. Okay, you need to be cautious with these medications because they are dangerous medications. They can lead to arrhythmias. So you need to start at low doses and you gradually increase. And the patient should be monitored under monitoring. So he should be on a critical care unit, either in the CCU or in the ICU. So this patient should be monitored continuously. So the inotropes they can lead to sinus tachycardia as side effects. They can cause atrial fibrillation, unstable atrial fibrillation. They can lead to myocardial ischemia because when the heart becomes faster, the heart will need more oxygen, and these patients are usually hypoxic. So it will be like a state of ischemia. You call this type 2 myocardial infarction. There's an increase also in mortality when we use these inotropes. It has a risk of increasing mortality. So we need to always monitor these patients closely, monitor the urine output, monitor the heart rate, the blood pressure. So the patient should be in a closed intensive care unit. So sometimes when we use dobutamine, sometimes we can't control the blood pressure alone with dobutamine, so we need to put a vasopressor. So norepinephrine is not an inotrope. It doesn't act on the beta 1 receptor to increase the contractility of the heart, but it acts on the blood vessels, on the alpha 1 receptors here, in order to cause a vasoconstriction. So when we do vasoconstriction, the blood pressure will increase. It's mainly the vasoconstriction of the vital organs. So in order to have blood reaching these vital organs. So it will cause vasoconstriction, the blood pressure will goes up a bit. It will help in treating this combination. So combining norepinephrine with inotropic agents like dobutamine might be considered, especially in patients that have advanced heart failure and cardiogenic shock that are refractory to dobutamine and furosemide alone. So we still have a low blood pressure and low urine output, and in that case, you need to add a vasopressor in order to try to increase the blood pressure, because when you increase the blood pressure, the urine output will improve, and when the urine output improves, the congestion will decrease as well. So we can help him by giving norepinephrine, but it's not the first line. Dobutamine is the first line. Okay. So we'll skip this. And here is the guidelines. So the TSC guidelines of acute heart failure. I will just focus on the class 1. So we should always put oxygen when the oxygen drops to less than 90% as saturation, or less than 60 millimeter mercury as dissolved oxygen, so hypoxemia or hypoxia. We should intubate the patient when we suspect respiratory failure. We should intubate him directly. Loop diuretics like furosemide intravenously should be administered for all patients in volume overload. So it's very important to decrease the volume overload for these patients. Okay, so here's the class 3. So we should not recommend these things. So inotropes should not be used routinely for all patients because of the risk of side effects. So we just use them for the patients that needs them, not for everyone. Okay. So here is a nice table that shows you all the inotropes. So you have the dobutamine, like we said. Dobutamine will act on the beta 1 receptors. So beta 1 receptors are the receptors that are present in cardiac myocytes in order to increase the contractility of these cells. So the indication is cardiogenic shock, decompensated heart failure, and the doses we already mentioned. So 2.0 to 20 microgram per kilogram per minute. And we should not exceed a dose of 40 microgram per kilo per minute because of the risk of tachycardia, of the risk of arrhythmia. So it's a dangerous medication that can lead to mortality. Dopamine can also be used, but we don't frequently use it for cases of like this. So you just need to know that it acts on dopamine receptors and on beta 1 receptors and alpha 1 receptors. So it's dobutamine is more selective. It more acts on beta 1. Dopamine acts more on multiple receptor, and it's dose dependent. So when we increase the dose, it will act more on the alpha 1 receptor, for example. Norepinephrine, we said it's not an inotrope. It's a vasopressor, so we use it in shock, like in case of septic shock or a refractory cardiogenic shock. So you can give 0.01 to 3 microgram per kilo per minute, and it acts most importantly on the alpha 1. So alpha 1 receptors are found on blood vessels, so he will have vasoconstriction. So just focus on dobutamine and on norepinephrine. These are the two most important ones for our patient. So it's recommended sometimes to use smaller combined dose of inotropes and vasopressors. Sometimes it's better than to use just one inotrope, for example, at a high dose. So they recommend sometimes to combine these two and to use small dose of each one. Okay, so because when we increase the dose a lot, there is a risk of increasing of the side effects. So if you combine both at a smaller dose, so this is important to avoid a lot of the side effects. So they tend to recommend this to use lower dose of each. Okay, so now we talked about this case. So it was a case of decompensated heart failure. As a case two, we see that the patient, he was unstable, he was hypotensive, he was in acute cardiogenic shock. So we put him on furosemide IV. We put him also on dobutamine, and we monitored his urine output, and the patient improved, and he was discharged 7 days later. So we discussed a case of acute decompensated heart failure that was very well responsive to medications. Now we move to the third case of this lecture. So it's another case. It's a case of the 65-year-old female. So it's an elderly female. She came. She was previously healthy. No past history. No past conditions. So she came to the emergency department for high-grade fever and cough since 72 hours. So it's very important when you have a patient coming for fever to ask him since when he is having this fever, because when we have fever of acute fever, so 3 days, 2 days, you need to think of a bacterial or a viral infection. Well, if the fever is from 1 month, for example, here you have another differential diagnosis. So the patient, she was given amoxicillin before coming to the ED, but she didn't respond to amoxicillin at all. Her cough was increasing in intensity. Her fever was reaching 40 degrees at home. So she came hypotensive and febrile with decreased mental status. So she was very complicated when she arrived to the ER. You can see that she was tachycardic, she was hypotensive, she was febrile, and she desaturated a bit to 88% on room air. So the tachycardia here in this patient is a reflex tachycardia. So always when we have high temperature, the heart rate will goes up as well as a response. So here we suspect that this tachycardia is a response to the high fever. So you should not try to decrease it, because if you decrease it, you will make the condition a lot worse, because here it's a reflex mechanism to keep the cardiac output preserved. So we should not drop the heart rate in that case. So a chest X-ray was performed. You can see here the heart. The heart is not enlarged. Why I looked at the heart? Because here we have hypotension, you have hypoxia. So you always need to eliminate heart failure. This patient does not have any signs of heart failure. The heart is not enlarged. But if you look here on the right lung, you can see a consolidation in the middle lobe. So this is a pneumonia. So this patient had a lobar bacterial pneumonia in her middle lung lobe. So the patient hypotensive, febrile. So we diagnose here sepsis due to bacterial pneumonia. So the first thing to do in case of sepsis is to give excessive fluid administration. So you need to give a lot of fluids with normal saline. But this patient, despite giving her normal saline, she remained hypotensive. And we started broad spectrum antibiotics. So initially, you should initially start the fluid with the broad spectrum antibiotics together to decrease the mortality. And after that, the patient kept on deteriorating. So we started her on Levophed, which is norepinephrine. And we placed a central line catheter in order to, because this medication, it's better to give it in a central line. You can give it in a peripheral line in cases of emergency when no one can, when no one is capable of putting a central line. But when you can't put a central line, it's better to give norepinephrine in a central line. So here are the recommendations from Critical Care Medicine Journal when they talked about sepsis. So they mentioned that for all adults that have septic shock, So we have a bacteria that in circulating in the bloodstream causing vasodilation and hypotension and high-grade fever. So norepinephrine is the first line vasopressor medication. So we have a lot of vasopressors, but norepinephrine is the first line. If the patient still remains hypotensive despite adding norepinephrine, we can combine vasopressin with norepinephrine. This is another vasopressor also, so you can combine norepinephrine with vasopressin. And if the patient is still hypotensive despite norepinephrine and vasopressin, in that case, you can add epinephrine. So you start always with norepinephrine with fluid with antibiotics. If the patient remains hypotensive despite norepinephrine, despite antibiotics, despite aggressive fluid administration, in that case, you add vasopressin, you monitor a bit, you see the blood pressure. If it remains that low, in that case, you can add epinephrine. So in case of severe cases, but when we reach the stage of epinephrine, you need to know here that the mortality rate is very high. So here is also from the same article. You can see the title if someone is interested to look at this article. You have the title here. So as we said, epinephrine as a first vasopressor, you should target a mean arterial pressure of 65 and above. And you should here start considering at this stage to put an arterial line, because an arterial line will give you the blood pressure variation instantly. So you can see it on the monitor, the blood pressure, you can see the pressure curve, so you can here monitor the dosages of the vasopressor more accurately. So you know when to increase the dose, when to decrease the dose. And if you can't put a central line, you can start the vasopressor. You can start the vasopressor in the peripheral line. And if it remains low, the mean arterial pressure, you add vasopressin, as we said. And if it also remains low, the blood pressure after vasopressin and norepinephrine as a third line, you can use epinephrine. So as we said. Sometimes the patient can have a combination of septic shock and cardiogenic dysfunction as well. So if a patient with already known cardiac dysfunction, he can present with septic shock due to an infection. So in that case, we start with norepinephrine, but here if we need to add another drug, it's better to add dobutamine and not vasopressin, because here we have also cardiac dysfunction associated with septic shock. So norepinephrine with dobutamine in that case, not norepinephrine with vasopressin and epinephrine. Here norepinephrine, then add dobutamine to it. Okay, so you always need to look on the history of the patient and try to do an echocardiogram in the emergency department if possible, in order to check if you can hydrate the patient. If he has cardiac dysfunction, you need to avoid hydrating him a lot. So you need to put him on dobutamine, for example. So for all adults with septic shock, you need to put them on invasive monitoring, arterial blood pressure. You need to put an arterial line. If we can't put an arterial line, as we said, you need to start them peripherally on the peripheral line, and then put the central line wherever possible. So here is another nice table. It summarizes the inotropes. So we said the most important one is dobutamine. It acts on the beta-1 receptors that we find in cardiac myocytes to increase the contractility, while norepinephrine is a vasopressor. It's not an inotrope because it does not increase the contractility. Here it acts on alpha-1 receptors that are found on the peripheral blood vessels. So it will cause vasoconstriction, and in case of septic shock or sepsis, we said the problem here is vasodilation due to the bacteria that is circulating and secreting as a cytokine in the circulation, causing vasodilation. So in case of septic shock, the most important vasopressor to use is norepinephrine. While in the case of cardiogenic shock, the most important inotrope to use is dobutamine. So if you just focus on these two, you can treat both septic shock and cardiogenic shock. We said also if the condition remains uncontrolled, we can add vasopressin, we can add epinephrine, but the first lines are norepinephrine in septic shock and dobutamine in cardiogenic shock. So sepsis, like the case of our patient, is a life-threatening organ dysfunction. It's caused by dysregulated host response to infection. So we have an infection circulating in the bloodstream. For example, in our patient, he developed pneumonia at the beginning, but then the bacteria translocated to the bloodstream and it starts its secretions, secreting cytokines and causing vasodilation and hypotension. The host immune system will also act against this bacteria, and the immune system will also secrete inflammatory mediators, which will make the condition worse. So the vasodilation will increase, the fever will increase, so it will complicate the condition. But this is how our immune system works. So in case of sepsis, we have organ dysfunction. So associated with dysregulated host response. So the immune system is also acting against this infection. So when we talk about septic shock, so septic shock, we have sepsis, we have bacteria circulating, we give hydration, we give antibiotics, but the hypotension persists. So when you have persisting hypotension despite resuscitation, so in that case, we start talking about septic shock. So we're in a state of shock. The hypotension should be associated with serum lactate above 2 millimole per liter. So when you have high serum lactate, we can diagnose shock, we can diagnose end organ hypoperfusion. So less blood is reaching the organs because we have vasodilation. So when we have vasodilation, the blood will circulate poorly and will reach the distal organs less than in a normal individual. So septic shock means persisting hypotension despite fluid, despite antibiotics, despite vasopressors associated with high serum lactate. So this is how we diagnose septic shock. And when we reach this condition, you should know that hospital mortality will exceed 40%. Okay. So when we have a suspected infection, you will always have to measure the Q-SOFA score. If you look here, the Q-SOFA, so if the patient has abnormal respiratory rate, he will get a score of 1. If he has abnormal mental status, score of 1. If he's hypotensive, he will get a score of 1. So if you get a score of 2 and more, here sepsis is likely. So in that case, you have the B SOFA score. It's not the quick, the full SOFA score. If also you get a score of above 2, then you confirm sepsis in that case. And when you confirm sepsis, so you start fluids, you start fluids, and you start antibiotics, and you start vasopressors as needed. If the patient remained hypotensive despite vasopressors and despite fluids, and he has a serum lactate of above 2, like we said, then we reach a stage of septic shock. So here 40% mortality. Okay, so in hospital mortality, it will be 40% when we reach the stage of septic shock. So when we diagnose the patient with sepsis or septic shock, so immediately we should take a measure serum lactate. We should check if it's above 2 or if it's less than 2. When it's less than 2, it's more reassuring. We should directly take blood cultures before starting antibiotics, because if we start antibiotics before taking blood cultures, sometimes the culture will become negative. Okay, so lactate, blood cultures, then antibiotics. Then you need to start hydrating the patient at a rate of 30 milliliter per kilogram. So we need to give a lot of fluids. It's very important. And you can start applying vasopressors also. If you have a central line, you can start it directly. You can start it in the peripheral line at a lower dose if you need to start it emergently and you don't have a central line. So it's very important also to keep the patient monitored. So he should be attached to a monitor in a critical care unit, should be attached to oxygen if needed as well. So within the first 3 hours, what you should do? Within the first 3 hours, measure lactate, take blood cultures, start antibiotics, and hydrate aggressively. If you do this rapidly, you decrease mortality. Vasopressors should be started within 6 hours. You should not delay. Every hour delay in starting vasopressors in septic shock will cause an increase in mortality. So increase above 40%. So reach 40, 50, 60%. So it's very important to start vasopressors before the 6 hours period. If you can do all of this within 1 hour, so in that case, you can have mortality benefit. You should begin immediately when we suspect septic shock. So measure lactate directly in the emergency department, blood cultures, antibiotics, fluids, vasopressors. If you can start them within 1 hour time, here you gain in mortality and you gain also in long-term survival for these patients. So what kind of fluid can we give? We said we should give them fluid at a rate of 30 milliliter per kilogram IV. So personally, I use crystalloids, so either normal saline 0.9 or lactated drenchers. Normal saline is the most frequently used. So either you give 30 milliliter per kilogram over 1 or 2 hours, or you can give, for example, boluses of 500 milliliters. So you give them over a few minutes. You give them, for example, 500 milliliter over 5 to 10 minutes. You check the blood pressure. If it's low, you can give another one, another bolus, 2 to 3 boluses. If the patient does not improve, then here you need to start him on vasopressors. You need to start antibiotics with the serum perfusion. You should not delay the antibiotics at all. You should start antibiotics very, very rapidly. So what is the goal of therapy? So the goal of therapy is to have a mean arterial pressure of above 65 and to have a urine output of above 0.5 milliliter per kilogram per hour. So a patient of 80 kilograms should have a urine output of a minimum of 40 milliliter per hour. Okay. And if the patient drops his MAP to less than 60 or he becomes unstable, then you need to start him on vasopressor within the first hour. It's very important to start it within the first hour and not to delay it. You should start it when you suspect septic shock, start it if the patient remains hypotensive. Okay. So here is a summary of what we said. So we initiate norepinephrine to target MAP of 65. If the MAP is not achieved, then you need to add vasopressin. So we start with norepinephrine, we add vasopressin. If still not achieved the MAP, then we need to add epinephrine as a third line. And if still with epinephrine we can't control it, the blood pressure remains low, you can add phenylephrine, which is also another vasopressive medication. If the MAP is achieved, so you have MAP of above 65, you can continue the medication. You can start tapering the dose. When the patient start to improve, you taper the dose down and you can stop it 24 to 48 hours later. You need to make sure that the patient is on the appropriate antibiotics. He's very well hydrated. Then you can start to taper down the norepinephrine dose when the mean arterial pressure is achieved. Okay, so I will show you the last case. It's just 2 to 3 slides. The last case is a 70-year-old male. He was previously healthy. He presented with syncope. So he lost consciousness completely. And when he was transferred to the emergency department, his vital signs, he had a blood pressure, he had a heart rate of 30. So he was bradycardic, severely bradycardic, and he had a low blood pressure as well. So this patient, if you look on his ECG, you can see the ECG here. You always measure the heart rate. So here the heart rate is very low. We said it's 300 divided by the number of big boxes. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So it's about 30 beats per minute, the heart rate here. After that, you need to check if it's regular or irregular, as we said in the first lecture. So here the heart rate is a bit irregular, but you look now on the P waves. So you have here a P wave, you have here a P wave, you have here a P wave. Maybe this is a P wave as well. This is a P. This is a P, non-conducting P waves. You can see that these P waves are not related. You can see that these P waves are not related to the QRS complex. So here we are facing an advanced heart block situation. So it's either here we need to act rapidly. So what should we do here? we need to place a pacemaker for that patient to treat his AV block. You will have another lecture on AV block today, but this is an unstable patient. You need to know that he can become hypotensive when his heart rate drops. If there is no one to place a pacemaker immediately, you can start the patient on a medication, isoproterenol, which is a medication that can uh, increase the heart rate for this patient, awaiting the implantation of the permanent pacemaker to treat his condition. So this medication is a non-selective synthetic beta-adrenergic agonist, so it will act on beta-1, beta-2 receptors. It doesn't act a lot on alpha receptors, so it does not affect the blood pressure. It will just increase the heart rate. But when you increase the heart rate, automatically the blood pressure will increase. Okay, so it's a powerful chronotropic and inotropic effect. So it will increase the contractility. It will increase also the heart rate. Okay, so this medications we can use it as a bridge before putting the pacemaker or awaiting for the physician to arrive in order to put the pacemaker. We said it's a non-selective beta receptor, so it acts on beta 1, beta 2, and it has zero affinity to alpha receptors, so it just increase it will increase heart rate and the contractility. It will cause a bit of vasodilation, so it may sometimes cause hypotension because it will act also on beta 2 receptors. Beta 2 receptors can also be found on peripheral vessels like alpha 1 receptors, but here the situation is vasodilation. So when the medication reaches the beta 2, it can sometimes cause hypotension. So you can see here the side effects, it can be hypotension. And that was my presentation of managing patients with altered hemodynamics. If you have any questions, please write them in the chat box. Okay, thank you for listening. I hope it was clear for you. If you have questions, you can write them. I'm still here, I can answer them. Okay, we will take a break till 10:30, and we will be back at 10:30. Okay, so 30 minutes break.
Can you hear me? السلام عليكم، تسمعوني بشكل كويس؟ الصوت واضح والسكرين واضحة؟ Hello. Okay, thank you for joining the webinar, and we will about the remote patient monitoring. فإذا نحن الهدف من عم نضوي على how to monitor a patient, how to remotely monitor a patient. Now, as you know, the ECG أو مراقبة تخطيط قلب المريض أو it's very important, especially in the highly critical area، سواء كنا بالاي سي يوز او بالكاردكس اي سي يو او بالemergency. We have what we call the monitoring area where all the patient are connected, all the patient are connected to one monitor. يعني بنشوف كل مرة مثلا إذا بنشوف بالكاردك اي سي يو صحيح كل مريض عنده for they have his own monitor. Okay, but at the end all of them they are connected to one central monitor. فإذا كله بيكون connected على central monitor. Why؟ حتى بالemergency نحن part of the emergency the first intervention is to monitor the patient, especially those who are in a يعني a highly critical condition. طيب but you know emergency it's يعني الشغل فيها بيصير بشكل جدا سريع. يعني you might have a stable patient suddenly you have a code. مشان هيك كثير نعمل close monitoring للمريض. Here in this session رح نفيزها مثل ما نحن عم نركز how to monitor hemodynamically monitor the patient and how to monitor the patient through the ECG. هلا نحن بالسيشن الأولى الدكتور انطوان شرح لكم عن البيزك اي سي جي انتربريتيشن. رح اعيدها بشكل سريع تنعرف شو الكومبوننتس، لانه اذا ما عرفنا شو الكومبوننتس it will be very hard to نعرف شو انواع الاي سي جي، سواء الانتريال فنتيكولار و to analyze a code. فاذا مثل ما حكينا بالسيشن الاولى، دائما الكومبوننتس we need to look after the components if they are available، هي اللي بي كيو ار اس تي. how they without they need to be available. how they بيعطونا فكرة انه the patient is doing well. يعني اذا جبت مريض who is fully conscious oriented and I connect him to the monitor, the expectation انه this all the components to have the PQRST. دايما very important that the P wave, it's normally the P wave occur regulatory، يعني بتكون دايما available and always before QRS. يعني دايما بيكون في عندي انا دايما ال P it will follow the QRS او ال QRS before or the P it will be before the QRS. اوكي، يعني هودي لازم يكونوا ورا بعضهم. and usually it's rounded مثل ما شفنا هون it's like a round upright and it's 2 to 3 millimeters in height، يعني بالطول. and duration أهم شيء نطلع على duration هي 0.04 to 0.10 seconds as duration. فإذا هيدي البي مثل ما حكينا البي always needs to be followed. هيدي as P you need to know. فإذا مثل ما حكينا هيدي معلومة جدا مهمة. إذا بنطلع على ال PR interval اللي هي دائما هيدي بنسميه ال PR segment أو ال PR interval، هيدي كتير مهمة وقت بنحكي عن مريض عامل بلوك. هيدي بنعمل an analyze. فإذا very important to know that always it should be it should be constant. إذا بلشت حسب التايمنج اللي تكلمنا عنه بالسيشن الأولى and always فإذا كل ما طولت أو كل ما كانت constant بدنا نبلش نحكي على what we call the block. اوكي، وقت بنحكي عن ال QRS اللي هي كمان QRS interval بنسميها الميجرمنت it's very important. يعني نحن دائما وقت بنكون بالامرجنسي ما يعني نحن هون عم نعطيكم الكونسبت، ما في وقت انه نقدر انا يعني اقدر اقيس الوقت، بدي اعتمد على النظر. اوكي، فاذا نحن وقتها if you are monitoring our patient انا ما بجلس وبقعد I will count the square بقول 1 2 3 no، بعتمد على النظر بشكل كتير منيح. يعني انا بدي يكون by default I need to see P، بدي اشوف QRS بعدها، بدي اشوف ال PR interval مش كتير واسع ولا كتير ضيقة، وبذات الوقت بدي اشوف انه مثلا QRS هي الميجرمنت اللي هي بتكون 1 to 2 small square او 0.04 to 0.08 seconds whatever. بس انه بدي انتبه انا انه ما تكون واسع. يعني انا عم بعطيكم بهالسيشن الاشياء براكتيكال اكثر ما يكون اشياء كونسبت. وضحت؟ اوكي، فاذا انتم معي بهالموضوع بليز ركزوا على هالموضوع. فاذا هون رح نضطر على الناحيه العمليه اكثر ما يكون اشياء ثيوري و فاذا this is how to see it in case of emergency. فاذا حكينا عن البي وحكينا عن الكيو ار اس ونتكلم الحين فاذا this is the way فاذا P always it should be followed by a QRS. دائما ال P بيجي وراها ال QRS to analyze it. and أول شيء بنسميها ال ST segment اللي هي أكثر شيء شو يعني نحن ك health care practitioner وقت بنحكي عن ال ST أكثر شيء إمتى بنحكي عنه وبأي حالة. دائما بنقول نحن patient has ST elevation or ST depressed. بأي حالات نحن أكثر شيء بنتكلم عنه. يعني دائما نحن again this is practical أكثر ما يكون theory. يعني أمتى بقول أنا عندي ال ST elevated or in which case any idea؟ وتبلش أحكي عن ال ST segment elevated. مثلا بدي يكون على مريض MI myocardial infarction. اوكي، فإذا this is or elevation for example in case of have MI أو hyperkalemia وقت بيكون عالي ST elevation، or بتكون ST depression وقت بيكون في عندي hypokalemia or digoxin digital or toxicity whatever. فإذا هيدي بنحكي على موضوع ال ST سواء كان elevated أو سواء كانت depressed. اوكي and this is مثلا peak followed by QRS and ST segment. هودي 3 بارت اللي مفروض ركز عليهم، وعلى النظر بشوفهم اكثر ما يكون مثل ما حكينا على الاشياء هلا التي ويف كمان يعني the T wave peak represent the relative refractory period of ventricular repolarization. هيدي كمان we need to take it as P part, QRS another part, ST segment part, and the TU which is the last part. Then we need to مثل ما حكينا هون مثل ما شفتوا segment 5 millimeters or 0.2 seconds. Again بالemergency مش مطلوب منكم نعدوا square but you need to see it on this way. This is we call it a normal components of an ECG. أي مريض with a normal, this is the expectation and this is how it needs to be seen. اوكي، فاذا هيدي بس اعطيتكم رح اضطر يعني انا اغير شوي بالسلايد بشكل اسرع لانه لا اقدر اعطيكم، فهيدي از كويك ريفيو على الموضوع. طيب إذا بنروح على القسم الثاني رح أحكيكم شوي عن الاتريال وعن الفنتريكولار. أوكي بس جست طيب ناو رح أحكيكم عن الفنتريكولار. شو معناتها، شو الفرق بين الاتريال والفنتريكولار؟ Do you have any idea؟ إذا what are the ventricular and the atrial من ناحية الأوريجين؟ إذا what are the difference between the atrial and ventricular? Do you have any idea؟ إذا نحن مثل ما حكينا في عنا two part بالاي سي جي، في عنا what we call the atrial part and we have the ventricular part. And what are the difference between these two؟ مين ممكن؟ فإذا الاتريال origin refer to the generation of electrical impulse within the atria of the heart. فإذا ما تحكي عن الاتريال فإذا you know it's essential from the atria of the heart and هي شغلة it's very essential for maintaining proper heart rhythm and function. فإذا the origin of atrial it's from the atrial فإذا والventricular from where is the electrical or the atrial from the atrial. Ventricular from where then it will within the ventricular of the heart. شو الرول تبعها؟ It's very important. أهم شيء شغلة جدا مو for maintaining cardiac output. فإذا بتلعب دور كثير مهم بالcirculation. هلا في بعض الميديكال term that you need to know. وقت بنحكي عن pulseless مثلا بنحكي عن هلا على الفنتريكولار ريزم او عن طيب وقت بنحكي عن for example عن الورد pulses وقت بنحكي patient has a ventricular tachycardia or pulseless ventricular tachycardia. شو الفرق بين الاثنين؟ Any idea؟ فإذا if you have a patient on VTAC or on pulses VTAC, what are the difference and what are the treatment؟ Any idea؟ عندكم شي فكرة عن الموضوع؟ طيب وقت بنحكي عن البالسلس فيتاك يعني كلمة البالسلس بتعني there is no pulse. مثلا كلمة البالسلس بتعني إنه المريض there is no pulse. وقتها نحن أنت شو الانديكيشن there is patient no pulse فإذا you need to provide the patient with a shock. أوكي فإذا هون رح نحكي أول شيء عن الفنتريكولار tachycardia and you know and how to treat it. طيب فإذا ventricular tachycardia مثل ما شفتوا كيف بدنا نعمل analysis؟ شو الفرق؟ I might have a ventricular tachycardia or pulses VTAC. طيب إذا بشوف أنا ventricular tachycardia or VTAC how to identify the rhythm؟ فإذا the VTAC may originate from an ectopic focus in either ventricle. أول شيء شو لاحظت فيه؟ إذا بنلاحظ نحن تكلمنا أول شيء عن الكومبوننت اللي هي PQRST يعني أنا for the first impression or the first analyze أنا مفروض في أشوفه. Let's analyze and see it here. فإذا are you able to see the P؟ حدا قادر يشوف منكم ال P هنا؟ إذا are you able to see the P here؟ إذا here أنا for me يعني it's not visible, but if visible it's appear when there is no relationship with BDQRS. يعني أجل نقدر نشوفها and maybe it's not existing or barely you could see it, but there is no يعني ما بشوف مش واضح لأنه ال P is followed by QRS. The QRS complex is wide and bizarre، يعني مش على same constant، تحسوها إنه واسع. فإذا this is the ventricular tachycardia. حتى سواء مجرد ما أشوف هذه always I need to take the pulse. فإذا إذا كان المريض pulse there is no pulse means he is coded. رح نشوفها بالسيشن الثاني. will announce a code. نروح على موضوع الشوك وموضوع السي بي ار ولا موضوع الابنفرين والى اخره. طيب here what to, if you have a patient he has this rhythm عنده الفيتاك but there is pulse، يعني مش pulse there is pulse here. what will be the line of treatment؟ فإذا ممكن يكون عندي مونورفيك فيتاك or polymorphic فيتاك، يعني كذا وحدة. طيب what will be the cause أول شيء تبع الفنتريكولار tachycardia؟ برجع بحكيك من هون. this is non يعني مش pulses. هون there is pulse. Sustained monomorphic VTAC is often associated with underlying heart disease. فإذا أكثر شيء المرضى اللي بيكون عندهم heart disease they might end with ventricular tachycardia, particularly myocardial ischemia, and it will happen with patients without underlying structure. فإذا إيش هي الأسباب؟ ممكن تكون cardiomyopathy، ممكن تكون نتيجة myocardial contusion، invasive cardiac procedure، valvular heart disease. ممكن تكون بالأخص دائما الإلكترولايتس imbalance أول شيء بتعطي الأفكت على الهارت. يعني الهايبو if patient with hypokalemia, if patient with hyperkalemia and hypomagnesemia, this is it might cause a ventricular tachycardia. مثلا هيدي الأسباب مشروطة it's mainly related to electrolytes and cardiac problem. It might cause a ventricular tachycardia. كيف نحن ممكن نشوف how we see the patient on ventricular tachycardia؟ هذا كيف نحن ممكن نشوف مريض what are the clinical symptoms اللي in addition to when you touch the patient to the monitor you will analyze and you will see them. What are the clinical symptoms of the ventricular tachycardia؟ shock، chest pain، مريض يجيك with chest pain، hypotension، shortness of breathing، pulmonary congestion، congestive heart failure، acute myocardial infarction and decreased level of consciousness. هذه أكثر العلامات اللي بتبين عند المريض أو this is the clinical symptom. فإذا مثل ما حكينا أهم شيء نحن وقت نفوت موضوع الاتريا والفنتيكولار بخاصة الفنتيكولار I need to check the pulse. وقت الموضوع في pulse اللاين اوف تريتمنت بيختلف if there is no pulse. وقت ما بيكون في pulse coded the patient وبروح على موضوع الشوك. إذا ما بعطي أنا شوك إلا بحالة وحدة إذا عندي pulseless VTAC or VF رح نشوفها. downwards أنا لأنه ممكن يكون مش بس شوف أنا الريزم pulse VTAC دغري بيعمل شوك، لا بدي أطلع على البالس لأنه إذا في pulse بيختلف التريتمنت. مثلا هير رح أشوف أنا مريض عنده ventricular tachycardia بس عنده pulse، إيش أسوي؟ فإذا if the patient is stable يعني المريض stable بعطي amiodarone and magnesium replacement and synchronized cardioversion رح نشوفها. طيب if مريض there is no pulse إذا شو بنعطي؟ CPR رح نشوفها defibrillation، epinephrine oxygen and anti-arrhythmias medication like الاميودارون واللايدوكاين. إذا هيدي if there is a patient he has a ventricular tachycardia. إذا الريت مثل ما شفتها this is how to analyze. في wave مثل ما حكينا it might be present or absent، مش واضحة بالنسبة لي. فإذا ومش there is no clear relationship between the P and QRS. the PR interval it's not existing, I cannot see it. وال QRS duration as you see it's more than 0.12 seconds، يعني من النظر بتشوفوا ان اتس واي. بس اهم شيء since you identify a rhythm شيك على البلس مشان اعطي البروبر line of treatment. ومثل ما شفت الريس it's very fast 101 it might reach to 250 beats per minute. إذا هيدي من شان قال طيب حروح على مشان لأنه مثل ما حكينا بروجرام فأروح على ال ventricular fibrillation. Who would like فأنا الفيتاك وضحت كيف ممكن how would you analyze it إذا شوفوا لي أول شيء how to analyze. فإذا مثل ما حكينا أول شيء أنا بدي أطلع على ال components. Can you identify the components here؟ إيش واضح بالنسبة لكم هنا بالسلايد؟ Are you able to see any components؟ وين البي؟ مثلا البي واضحة بالنسبة لكم؟ مش واضحة. وين الكيو ار اس؟ مش واضحة. وين التي؟ وين البي ار انترفال؟ هيدا اللي قلت لكم اياها من حوالي العشر دقائق شفيتكم اياها على السلايد. ما في عندي اي شيء واضح. اوكي فاذا ما عندي اي شيء واضح فاذا هون ما بقى عندي it's a bizarre nothing is I cannot identify anything. فاذا هون كمان ضروري بكل الحالات بكل الرزم I need to check the pulse. ما في pulse. مثلا here I will go for ممكن تكون this is another one and this is مثل ما حكينا فإذا الريت cannot be determined. ما بقدر أشوف الريت يعني ما بقدر أعده. الريزم rapid no pattern or regularity ما في أشوف. P ما بقدر أشوفها. PR interval كمان I cannot see it. QRS ما في شوفها يعني أصلا مش واضحة بين عندي QRS. ساعة واضحة ساعة واسعة ساعة ضيقة ساعة مش موجودة ساعة very close to each other ساعة يعني ما مثل ما زبنا هيدي يعني موضوع ما بقدر أعمل identification في أي شيء. فإذا المفروض في هون شيك على البلس. إيش هي الكوز كمان؟ ممكن مثل ما شفتوا vagal stimulation hypokalemia anti-dysphagias and other medication ممكن تسبب hypertrophy myocardial infarction cardiac failure abnormal repolarization كلياتها it might cause a ventricular fibrillation. What to do in case رح نشوفها بالكود بالسيشن الثاني what to do in case then we need to start CPR and to give a shock and epinephrine and هون في عندي كمان النوع الثاني ألا وهو الاسيستولي. حسب رأيكم فإذا إيش ممكن how identified a rhythm. لازم نعطي شوك بهالحالة مثلا what do you think؟ أنا عندي هيدا الريزم what to call this rhythm and what to do in case you have عم تعملوا مونيتورنج لمريضكم انتم بالطوارئ جالسين على التليمتري بنسميها او تليمتري روم وعم كونكتد كل المرضى هون وشفت مريض فجأة بالطوارئ عنده هيدا الريزم which is asystole. ايش نتصرف؟ what to do؟ and I found my patient has this rhythm what can I do؟ Present. As definition, a systole is a total absence of ventricular electrical activities. There is no ventricular rate or rhythm, no pulse or no cardiac out. طيب هون أنا كمان شغلة جدا مهمة. أنا مش دغري بروح على الاسيستولي از اسيستولي لأنه أنا كثير بتصير بالأخص اللي بيشتغلوا بالطوارئ بيعرفوا إنه هذا الرزم بشوفه كثير. ليه؟ مش لأنه المريض عنده اسيستولي لا أنه ممكن المريض يكون الليد تبع الاي سي جي not connected very well او المريض he's agitated او الى اخره يعني. هيدي اللي بيشتغلوا بالتليمتري بالاي ام اس يعرفوا هذا الموضوع كثير منيح انه المرضى بيكونوا كونكتد على المونيتور بس فجأة فور اي ريزن عندي عدد كبير من المرضى بشوف مش معناتها عنده اسيستولي لا. كثير مهم وقتها بشوف هيدا الريزم انا اروح وشيك وشوف انه المريض ما عنده هيز كونكتد. اذا ما كان كونكتد بنفوت بالموضوع الثاني مثل ما شفنا هون. فاذا الريت الفنتريكولر not discernible يعني أنا ما بقدر أشوفها. كمان الريزم ما بعرف أي شيء يعني. it's not detectable very well. P wave ما بقدر أشوفها ما في عندي بي ار interval ما أقدر شيك عليها والكيو ار اس duration absent. فإذا here what will be إيش هي الكوز تبع هذا الموضوع ممكن تكون pulmonary embolism هذا ممكن تكون pulmonary embolism أكتر شيء، هي this is the main or the main reason. tension pneumothorax, cardiac tamponade, hypovolemia, hypoxia, hypothermia, myocardial infarction. فإذا هيدي الأسباب. how to treat. فإذا أهم شيء دايما مثل ما شفتوا بكيروريزم عم ركز على confirm the absence of a pulse. أهم شيء شيك أو إنه هالبلس فعلا موجود ولا مش موجود. إذا confirm the absence. دايما بهالحالة CPR الشوك مثل ما حكينا ما بينعطى إلا البالسز بتاعك NVF and confirm the rhythm is two leads وإلى آخره. و IV line مثل ما حكينا والإبنفرين وتريت ذا كوز رح نشوفها بس لكم. فإذا هون this is for the uh, هون how would you pulses PEA or pulses electrical. فإذا أنا عندي shockable اللي هي pulses VTEC and VF وعندي non shockable اللي هي asystole و PEA. asystole وضحت لك PEA أو pulses electrical activity شو يعني؟ there is activities عم نقول pulses. شو معناتها كلمة pulses means there is no pulse. okay. فإذا this is the what we call the PEA or pulses electrical activity. مثل ما شفنا رح شوف يعني نشوف الكومبوننتس PQRST 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 كله واضح. البي ار انترفال لها، الكيو ار اس موجوده، الاس تي موجوده، كل الكومبوننتس موجوده وكل شيء موجود، بس المشكله ان there is no pulses. okay. and here it will be the same line of treatment as a the asystole. okay. الكوز كمان مثل ما شفتوا كتير أدمي بالمونري امبوليزم، اسيدوزس، تنشن نوموثوركس، تامبونيد، هايبوفوليميا، هايبوكسيا، هيت كولد، هايبوكاليميا ومايوكاردال انفاركشن. كمان نفس الانترفنشن تبع الاسيستولي سي بي ار اندوتراكيال انتوبيشن والى. إذا أي سؤال عن الفنتيكولار قبل ما نروح على الاتريال وضحت بالنسبة لكم؟ It's clear or do you want me to repeat? Great. فإذا let's move to the next one. اوكي. فاذا مثل ما حكينا يعني حكينا عن الفنتريكولار بارت رح نحكي عن الاتريال ورح نشوف هنا ايش هو يعني how to read it. فاذا from the first impression من ناحيه مثل ما حكينا بدنا نعتمد على النظر اكثر ما يكون على الورقه والقلم والكاونت سكوير والى اخره. كثير كان على قصه انه how could you see it. حسب رايكم how would you analyze this. طلع على الكومبوننتس عندي for example عندي P Q R S T PQRST. فإذا كل الكومبوننتس مش مثل الفنتريكولار فيبريشن ما مش واضحة بالنسبة لي. هون كل الكومبوننتس واضحة. أول شغلة يعني available من البي للكيو ار اس تي وإلى آخره. طيب الشغلة الثانية إذا بنشوف الار ار كيو ار اس مش واسع نورمال. ار اتس ريجولار، شفتوا ريجولار، كل شيء مظبوط. ايش عندي المشكل؟ انه الرزم هنا صار، يعني اذا بدي اعد 1 2 3 4 5 6 7 8 9 10 11 12 13 14 15 16 17 18 18 ضرب 10 108. فاذا هون عندي very fast rhythm، اذا هون عندي كثير سريع very fast rhythm 180. اوكي، هون I have a very fast، مثل ما شفنا يعني ممكن يكون الريت من ال 150 ل 250 regular، ودائما مثل ما شفنا كل شيء طبيعي. عندي انا البي ويف اتس اولويز افتر بروسيد كيو اتش كيو ار اس، بي ار انترفال موجوده والكيو ار اس اتس، فانا كل شيء نورمال، بس انا عندي a very fast rhythm. هيدي الاتر. وات از ذا تريتمنت؟ دائما انا وقت عندي ريزم فيري سريع كثير سريع بدي هدي الريزم. مثلا how to give by give the medication like what؟ نعطي الادينوسين، الاميودارون والبيتا بلوكرز والسينكرونايز كارديوفيرجن. نحن مثل ما شفتوا وقت بنعطي الشوك في عده انواع، في عندنا وقت بيكون there is no pulse بنعطي الشوك، وقت بيكون في عندنا ريزم فيري سريع يعني فيري فاست بدي هدي الريزم بعطي السينكرونايز كارديوفيرجن. فاذا نحن من ناحيه الاتريال بنعطي السينكرونايز كارديوفيرجن، مثلا السوبر فنتيكولار تاكيكارديا رح نشوفها، او الاتريال فلاتر او الاتريال فيبريشن. هيدي بهالحالة نحن بنعطي الكارديو فيرجن مثل ما شفنا. فإذا هون عندي أنا بنعطي من ناحية دائما أنا ببلش بالميديكيشن اللي هي أدينوسين أميودارون أو بيتا بلوكرز، وبعطي السينكرونايز كارديو اس في تي. رح شو فيكم شوفوا how would you analyze it. فإذا أول شغلة الوهلة الأولى يعني بتلاحظ إنه البي فايتي بالكيو ار اس فايتي بالتي، يعني جي فيري كلوز. ليش؟ مش لأنه مش موجودين، لأنه كتير سريع الرذم، بتشوفون كتير طحشوا على بعضهم. أوكي يعني زي ما تكون أنت واقف في تجمع. يعني إذا كان الوهلة الأولى الأشخاص إذا ما كان كتير مكتظة ممكن تشوف الأشخاص، وقتها كتير مزاحم الموضوع ما بتقدر تشوف حدا. هون نفس الخبرية، أنا الكومبوننتس هنا لأنه كتير كلوز تو ايتش أذر ما بقدر أعمل ايدنتيفيكيشن لأنه كله فايد ببعضه. عشان كده فإذا عندي ريزم فيري كتير سريع، 1 2 3 4 5 6 7 8 9 10 11 12 13 14 15 16 17 18 19 20 21 22 23 24، يعني واصل معي لحديت ال 250. يو كود imagine الشخص العادي الهارت ريت بده يكون من ال 60 لل 100، انا هون 220 which is very fast. يعني مثل ما شفنا هون البي اتس فايدة انتو تي ويف، يعني فايتة بقلبها مثل ما حكينا. فاذا very fast rhythm مثل ما حكينا. and دايما هون مثلا عندي very fast suddenly converted to sinus rhythm. كيف بنعمل التريتمنت؟ نحن دايما سواء المريض دايما ما في احكم على المونيتور بس. دايما انا في عندي مريض ممكن يكون صحيح عنده supraventricular tachycardia بس المريض هو ستيبل، ممكن المريض يكون عنده اس في تي بس المريض يكون انستيبل. فاذا انا ما في شيء 100% بيقول لي انه ستيبل او الا الكلينيكال سيمبتومز. فاذا دائما انا اللاين اوف تريتمنت بيعتمد حسب الستابيليتي. اذا المريض ستيبل فاذا ما بقول له روح على البيت، بقول له كيب اندر اوبزرفيشن. اذا المريض انستيبل ساعتها بتصرف. فاذا اذا كان المريض اس في تي مانجمنت، اذا المريض ستيبل فاذا we need to uh, stable patient with tachycardia with a palpable pulse can be treated with more consecutive measure first. فإذا نعمل الفيجال maneuver which is technique by which you attempt to increase intrathoracic pressure by stimulation of the vagus nerve. فإذا it will slow the conduction of electrical pulse through the AV نذكر عنها الاتريال. and this is فإذا this is the first thing. إذا المريض كان unstable مثل ما حكينا تذكروا من ناحية إنه بدنا نهدى الريزم نعمل asynchronized كارديو فيرجن. فإذا مثل ما حكينا If unsuccessful, not adenosine 6 milligram followed by 2006 milligram 12 milligram. أنا 6 milligram 12 milligram هيدي من ناحية هيدي من ناحية يعني السوبرفنتريكولار tachycardia. فإذا this is the line of treatment that we need to do. Okay, فإذا this is the line of treatment that we need to do it for the supraventricular tachycardia. يعترف حسب stability of the patient. ما في شيء يعني stable. This is the line unstable. فإذا بنروح على قصة synchronized cardioversion. كمان اذا بنشوف هون كمان هون اكثر شيء بيصير فيه تلخبط بين الاتريال فيبريشن والاتريال فلاتر. كله اتريال تاكيكارديا ريتم فيري سريع. بس شو هو المشكل هون؟ شفتوا شو الفرق بين الاتريال فلاتر والاتريال فيبريشن؟ عندك هون الريت فيري فاست على طول، و بس هون بنشوف شو الفرق بين الفلاتر والفيبريشن، انه هون اتس الار ار اتس كونستنت. اوكي، بينما بالسكند وان اتس نوت كونستنت، بتتغير، يعني it's irregular. And this is the same line of treatment. مثل ما احنا ايش هو السبب اللي هو ممكن تكون pulmonary embolism, thyrotoxicosis, ischemic heart disease, hypoxia and digital toxicity. And mainly goal of atrial flutter treatment is to control the heart rate. عندنا very fast rhythm, restore a normal sinus rhythm and prevent a future episode and prevent of ستروك. دايما مثل ما حكينا، شفت ركزت كثير على الموضوع على الستابيليتي والانستيبل. مريض ستيبل نعطي الميديكيشن ثرو انتي اريثميك ميديكيشن من ناحيه اميودارون او كالسيوم شانل بلوكرز بيتا جلوكوز. اف انستيبل بروح على السينكرونايز كارديوفيرجن. فاذا مثل ما لاحظتوا الاتريال ريزم اتس اولويز تريتد باي ذا انتي اريثميك ميديكيشن والسينكرونايز كارديوفيرجن. الاميودارون اللي هي 150 ملي جرام anti-arrhythmias followed by 350 milligram over 6 hours. إذن هيدي this is the atrial and the ventricle. فإذن this is هذا اللي بدي يعني الاتريال fibrillation كمان it's the same. بس لاحظتوا في فرق شغلة فرجيكم إياها mainly this is the same line of treatment. بس رح نشوف إنه شوفوا إنه الريزم it's irregular. إذن هيدي الاتريال وهيدي الفنتريكولر. رح أفوت على البارت الأخيرة مثل ما حكينا، ألا وهي الرابid sequence intubation. في أي استفسار معين عن الاتريال والفنتريكولر قبل ما أروح على الرابid sequence؟ any question؟ نضحت؟ جريت. فإذا give me 2 minutes أغير سلايد بكون على البارت تبع الرابid sequence intubation. اوكي. طيب نحن يعني مشان just because we have time for the program مشان نكون غطينا كل الاشياء المعتمده. طيب رح نحكي على موضوع يعني سواء المريض وتحكينا عن موضوع البالس there is no pulse. يعني بيجيك مريض على الطوارئ. For example, let me give you a case scenario. You have a patient coming with a chest pain. بيجيك مريض عنده chest pain. We connect him to the monitor and you closely monitor him. تعطي البروتوكول مونا بروتوكول هي نيتروجليسرين هيبارين semi sitting position oxygen administration and blood investigation cardiac enzyme Foley's catheter IV cannulation 12 lead EKG. طيب هذا المريض and you closely monitor him. إذا أنت and you closely monitor the distance. فجأة المريض after few minutes he deteriorated and he become unresponsive. إيش لازم نسوي بهالحالة؟ شو نسوي؟ إذا عندك مريض typically chest pain you put him under close monitoring. أعطيتيه نيتروجليسرين كل يعني you follow the chest pain protocol أو بنسميه المونا protocol and suddenly المريض become unresponsive and he fell down or he become unresponsive. What to do؟ إذا نحن أهم شيء مثل ما حكينا ليش بنحط هلا نركز عليه اليوم closely monitoring of patient. ليش حاطينه على الرزم أو على المونيتور؟ لأنه أنا بدي أعرف المريض إيش عم يصير معه. إذا مريض عامل تاكيكارديا مثلا في لاين اوف تريتمنت كلنا عامله. اذا مريض عامل براديكارديا وي هاف لاين اوف تريتمنت اوريدي وي ديسكاست. اذا المريض عامل بالسز فيتاك اور في اف كمان عندنا لاين اوف. طيب بكل الحالات وقت المريض بيكم ان ريسبونسيف and there is no pulse فاذا انا بدي اعمل announcement للكود. فاذا المريض هي از كودد بنعمل له announcement للكود. واهم الشغله انه بدي بلش بيجي الكود تيم ليدر. كل واحد بياخذ بارت سواء medication administration او بيعطي الشوك او بيعطي CPR. And one of the most important intervention is to secure the airway and to do a rapid sequence intubation. يعني من الأشياء اللي جدا مهمة إنه أنا أعمل يعني ما في خلي المريض على طول على الامبوباجينج at some point أنا لازم أعمل له الانتوبيشن أو الرابid sequence intubation. هاي شغلة جدا مهمة. بس this is كتير مهم. امتى بنعمل حساباتكم ليش امتى الحالات اللي بيلجأ فيها غير المريض انه unresponsive؟ ايش هي الحالات اللي بيلجأ فيها انه المريض نعمل له rapid sequence intubation؟ اعطوني بعض الحالات انا المريض بيلجأ اعمله فيها rapid sequence intubation. give me one case one example. مثلا مريض نحن عم نشوف الجلاسكوما سكيل مريض بوست ار تي اي وصار في عنده يعني لاحظنا انه decrease level of consciousness. كان المريض 15 over 15 رجع 13 over 15 فجأة صار 9 over 15 9 من 15. فاذا هي المريض خلاص كانت maintain his airway انا المفروض اروح على rapid sequence intubation. فاذا loss of protective airway reflex and إذا المريض respiratory failure مريض إجاني كان عنده respiratory distress فجأة على respiratory failure. المريض فجأة صار في عنده وصل saturation عنده severe cough وأخذت له إكس راي لاحظت إنه he has lung it's very يعني زي الثلج كتير infected وكتير والساتوريشن جدا واطي. فإذا أنا بهالحالة أنا بضطر على rapid sequence intubation. respiratory failure evident by increased work of breathing tachypnea desaturation and blood gas result of PSO2 less and PSO2 increase. إذا هون بهالحالة بقول إنه this category of people they need to go for this intervention. نحن وقت أنا بدي أروح على مريض عندي أنا I'm monitoring this patient وفجأة المريض he needs. فإذا نحن ليش المونيتور؟ ليش نحن بنعمل كلوز مونيتورنج؟ نحن هذا العنوان عم نتكلم عنه. ليش بنعمل كلوز مونيتورنج للمريض؟ لأنه المريض he needs to be closely monitored. يعني بأي لحظة he might pass away he might be in a life threatening condition. يعني هون المريض أنا عرفت إنه إذا ما عملت له أنا close monitoring أنا ما راح أعرف إنه he needs a rapid sequence intubation. ما في أعرف. أوكي إذا ما عملت له close monitoring. عشان كده نحن وقت أنا بدي أعطي أنا rapid sequence intubation هي مش مثل اي في cannulation حطيتها وخلاص، في preparation. يعني مش دغري بشيل التيوب وبحطه بالماوث تبع المريض وخلص مش الحال، لا. اتس نوت ذا واي. فاذا اي هاف a preparation بتبلش من البري اوكسجينيشن للبري ميديكيشن للسيديشن، بنحط دايركت لارنجوسكوب انتوبيشن، وبساعتها بنعمل انتوبيشن اند فيريفاي اند سكيور. فاذا مثل ما شفتوا البروسيس it will take time، يعني from 1 to 5 minutes، لانه في different steps. مش دغري it's not a matter to put a tube. في عندي اول شيء بدي اعمل preparing الايكويبمنت. رح نشوف شو هي الايكويبمنت. بنعطي بري اوكسجينيشن للمريض، بنعمل بري ميديكيشن، بنعطي السيديشن والباراليزس، بنعمل التيوب او دايركت لارنجوسكوب، وبنعمل انتوبيشن اند فيريفيكيشن. رح نروح على كل ستيب باي ستيب. Always we need to assess the risk, like if he has any allergy to anything, or medication allergy, or past medical history, last meal, and even what are the event. هيدي الايكويبمنت needed. إذا this is the equipment needed. You could see it. Like what؟ هيدي بنسميها الايرواي كارد. إذا this is including what؟ مثل ما شفتوا في عندي التيوب. هيدا التيوب اللي هو بفوت على بنسميه اي تي تي، اندو تراكيال تيوب، اللي بيفوت من فم المريض وبيروح على ثرو اندو تراكيال، يعني بيفوت انسايد ذا تراكيال، بيفوت على التراكيال وبيروح على تو لانجز. كمان هذا there is size. ايش هو السايز؟ do you have any idea؟ عندكم فكرة عن السايز تبع الاي تي تي تيوب؟ كيف يكون السايز؟ do you have idea؟ any idea about the size؟ إذا هون بيختلف. إذا البيدياتريك ببلش من 4 ونص 5 4 4.5. إذا الأدلت ببلش 7 6.5 7 7.5. فإذا هون حسب العمر وحسب الأخير. فإذا هون mainly يعني معظم 7.5 to 8. This is the mainly that you are using for us. سي سي 10 سي سي سيريشن مشان أعمل انفليشن للبالون، لوبريكانت مشان سهل دخول التيوب، وفي عندي الفورسبس، وفي عندي الاورال ايروي. What do you know about the oral؟ امتى بنستعمل الاورال ايروي؟ كيف how to measure it and how to insert it؟ شو الامبورتنس تبع الاورال ايروي؟ إذا الاورال ايروي هي there is no way to perform any intubation unless you have a oral airway. إذا الاورال ايروي أول شغلة ما بتستعمل عند مريض هو is conscious. ما في مريض يكون واعي وحط له اورال otherwise رح يبزقها. اوكي. فاذا الاورال ايروي هي سايز، دائما بحسبها على السايز. بدها تكون from the lobe of the ear till the mandible or the nose. بشوف السايز وبحط طبق العمر. يعني ما فيها تكون كثير كبيرة ولا ممكن تكون كثير صغيرة، لأنه إذا كانت كثير كبيرة بيكون في ليكينج، وإذا كانت كثير صغيرة الإير مش راح it will not reach the lungs. فإذا بدها تكون السايز، بدها تكون بروبر سايز، لا كبيرة ولا صغيرة، وهذا بيختلف حسب العمر. مشان هيك أنا عندي كراش كارت البيدياتريك وعندي كراش كارت الأدلت، لأنه كل شيء يعني أنا ما في أحط اي تي تيوب 4.5 لأدلت عمره 35 سنة و40 سنة. بذات الوقت ما في حط اورال اير واي للادلت لبيدياتريك بيشنت عنده 2 اور 3 years. اذا هون بتختلف سايز حسب العمر. فاذا كثير مهم يحط انا الاورال، لانه اذا ما فتحت how I'm going to deliver oxygenation اذا I did not open the airway. فاذا ضروري يحط الاورال اير واي، لانه اذا افتح مجال هواء اقدر deliver oxygenation للمريض. ال ATT type of fixation laryngoscope بلاد كمان هون بتختلف، يعني just كله حسب السايز وحسب المريض. and the laryngoscope handle هيدي المفروض فيها البليدز، فإذا هيدي كلياتها it needs to be ready. كثير مهمة. ما في أنا فوت على أعمل انتوبيشن لمريض ما يكون عندي الايروي، أو ما يكون عندي أنا السننج، أو ما يكون في عندي أنا اللارنجوسكوب، أو ما يكون في عندي أنا التيوب. يعني أقدر مريض استعمل لارنجوسكوب، استعمل بليد، واجيت احط تيوب، ما في عندي تيوب، عندي تركيب. فاذا كثير مهمه هيدي بنسميها ده preparation phase. it's very important. اهم شيء شيك، عشان كده نحن دائما بيكون في عندنا راش كارد جاهز وما يستعمل الا بحاله الامرجنسي. اذا وضحت عن الايكويبمنت. clear for the equipment. great. بنروح على كمان كثير مهمه additional equipment كمان بارت، انه يكون في عندي monitoring stethoscope monitoring، مش نشوف انا يعني المريض to hemodynamically monitor the patient and to حط الاي سي جي، اعرف ايش الرزم عند المريض. a bag valve mask attached to oxygen connecting tube, oxygen flow meters, a suction regulatory and suction consistor, tonsil step suction واورال and tracheal suction. suction كثير او اليانكر او الديسكشن كثير مهم، خاصة مريض عنده كاف، فمشان just to do it proper. And this is I need to have additional equipment كمان gloves, syringe, cardiac monitor because of vagal stimulation. and ليش بحط ال end tidal CO2 detector? Why? What is the important? وال IV line وال prepare medication. ليش ال end tidal CO2 detector كثير مهم؟ Why it is very important؟ لأنه أعرف مشان placement of that tube. part من اللي حنشوفه آخر شيء إنه تأكد إنه التيوب بمطرحه يكون في عندي CO2 detector. مثل ما حكينا هيدي كمان التايمينج تكلمنا عنها، يعني you need to know it. إذا هون نكون نحن خلصنا البارت الأولى وهي ال prepared the equipment. هيدي الايكويبمنت كل اللي عددنا لكم إياها، فإذا هي equipment ضرورية جدا تكون موجودة، لأنه ما بقدر أنا بلش عند المريض ويكون في نقص بأي وحدة من الايكويبمنت. Pre-oxygenation. إذا مش دغري I need to provide a 100% oxygenation using a bag valve PVM bag valve map. إذا how to place، كيف شو لاحظتوا شو بنسميها هيدي position. إذا what we call this position. any idea؟ إذا مثل ما لاحظتوا هون بنسميها السي. أول شيء بنشوفه المريض بده يكون head tilted chin lift، لأنه أنا ما في open the airway بلا الهيد تلت الا بحاله اذا كان المريض فراكتشر او عندي ماندبل فراكتشر او عنده تروما وبحط الجوتس. طيب هون بنسميه السي اي. شوفوا هيدي السي. this is the C and this is the E. C and E. thank you أمنية. and this is the E. بنشوفوا هيدي الإي. ها، واحد اثنين ثلاثة. سي إي. طيب شو بخصوص الماسك اللي هنا؟ what type of mask do I need؟ شو السايز وشو التايب and why؟ ليش كتير مهم يكون عندي proper size؟ شو هو التايب اوف that I need to put it. إذا كتير مهم السايز. it needs to cover النوز والماوث. يعني هيدي الاريا كتير مهمة، لأنه إذا كان كتير واسع رح يكون في leaking of air، وإذا كان مغطى النوز ومغطى الفم كمان it will I will not reach my goal. فإذا كتير مهم يكون في سايز. والكواليتي بدها تكون الكواليتي مش تكون يعني بور كواليتي وتسبب نوع من الألمنيوم أو الحديد مثلا تسبب تروما للمريض، يكون شيء نسي بموضوع ثاني. فإذا كثير مهم proper size and proper and how to deliver الأكسجينيشن على الباج. كيف نعطي الأكسجينيشن؟ كل قديش نعطي أكسجينيشن؟ how often you will give oxygenation. إذا how often you will give oxygenation. طبعا عشان نجهز الانتوبيشن اكسلنت. بس يعني وقتها انت هون عم تجهز، احنا بعدنا ما عملنا الانتوبيشن، بعدها بريباريشن. تذكر نحن تكلمنا عن البري الرابت بري، بعدنا بالبريباريشن فيز. هون بعطي انا مثلا سي بي ار 30 بعطي 2 اوكسجينيشن. اهم شيء شيك انه ما يكون في ليكينج. وكيف بعرف انه I am providing a good oxygenation؟ شو هي الانديكيشن؟ ببين عندي التشست رايس، ببين عنده انه الصدر المريض عم يطلع. اهم شيء شيك انه equals وعم يطلع complete chest rise. هيك ساعتها اهم شيء شيك انه chest of مريض is moving up، وما يكون في عندي leaking of air من هيدي النقطة. And this is the way how to provide 100. This is الجول انه to provide 100% oxygenation. بس اهم شيء انه الانديكيشن باين عندي انه مغطى الاريا كلياتها chest rise، وما بيكون في عندي leaking of air اقدر عم بسمعه او عم شوفه. طبعا الاكسجينيشن ساتوريشن تكون وزيكو. طيب فاذا هون بعدنا مثل ما حكينا بعد ما عملت الانتوبيشن بروح على الميديكيشن اللي هي بري ميديكيشن. بلش بالاتروبين. ليش بنعطي الاتروبين؟ mainly given for pediatric to prevent bradycardia، لانه بنعمل نحن وقت عم نعمل انتوبيشن والى اخره بدنا نعمل ستيموليشن للفيجل nerve during intubation. مشان هيك بنعطي الاتروبين to prevent bradycardia. اوكي، لانه المريض due to the stimulation of the vagal nerve رح يصير في bradycardia. عشان نعطي الاتروبين وبنعطي الانتي اريزنس ميديكيشن، لانه بالاخص اذا كان عندي head injury وين increase بكون في عندي increase intracranial pressure is. فمثل ما حكينا pre oxygenation والميديكيشن اللي هي مثل ما حكينا الاتروبين واللايدوكين. نعطي كمان الانالجيزا ميديكيشن لايك الفentanyl والمورفين والميثادون. كمان patient needs to be sedated. How I'm going to intubate the patient with no sedation؟ زي شو بنستعمل بنزوديازيبين او الميدازولان والكيتامين والبروبوفول. نحن يعني هلا طبعا مش مطلوب منكم تعرفوا كل شيء، نحن يعني اكثر شيء هي المعروفه الكيتامين بروبوفول والميدازولان او البنزوديازيبين، هي اكثر شيء معروفه. هيدي كلها بعدها بالبريباريشن الفيس، بالاضافه للباراتكس ميديكيشن لايك سكسينولين اند روكيرونيوم والى اخره. هي اكثر شيء يعني. اذا هيدي now what we need to do. هلا صرنا بالبريبريشن، كل شيء جاهز، الاكسجينيشن واعطيت السيديشن والانالجيزيك والفنتانيل والى اخره. الحين we need to intubate. We need to apply a cricoid pressure when indicated. Why do we apply a cricoid pressure؟ ليش حسب رأيكم we apply the cricoid pressure؟ What are the importance during intubation؟ شو أهمية الكرايكويد pressure؟ فإذا كثير مهمة and why we apply the فإذا هذه technique we use it during intubation. It will help to prevent aspiration of stomach content into the lung. فإذا بنعمل pressure على كرايكود كارتلاج، مش بنسمي كرايكود pressure، بنعمل pressure عليها منشان يعني يعني مثل ما حكينا just to avoid or to avoid pressure to the it will compress the esophagus against the vertebra مشان ما مثل ما حكينا ما يكون في عندي aspiration of the stomach content. It will use and used to help align the airway during endotracheal intubation. and مثل ما حكينا أكثر شيء تنعاز منشان to provide or to prevent the gastric contents from leaking into the pharynx, the external obstruction and the esophagus. فإذا هيدي أكثر شيء مشان alignment airway during intubation and to prevent gastric contents from leaking. إذا هيدي معظمها هي this is the indication of why we use this. And this is the pressure I will show you. يعني في يعني we have different name مثل ما حكينا بنسميها الترايكود بريشر، او ممكن انا واسع اللي بيشتغلوا بالارقام بيعرفوا بنسميها مثلا السيلكس مانر. مثل ما شفنا هيدي يعني هيدي اهميتها and this is how to do it. انك وضحت شو اهميتها السيلكس مانر او الكروكويد بريشر. الحين فاذا انا preparation phase it's done و شفت المريض medication الامبو باجينج I give oxygenation tube in place والventilation it's given to the patient. now كيف بدي أعرف أنا إنه that tube is in place؟ كيف بدي أعرف أنا إنه أو أتأكد إنه الintubation it was a great intubation or it was a successful intubation؟ فإذا إيش هي الكرايتيريا اللي لازم أعرفها أو لازم تبين عندي بتبين لي إنه يعني في عندي فإذا أهم شيء عندي 8 نقاط لازم أعرفها مشان أعرف إنه my tube is empty. أول شغلة direct visualization of the tube passing through the vocal cord. كيف يعني direct visualization؟ يعني فعلا أنا عندي مريض لارنجوسكوب وجبت مثلا tube 7.5 I introduce it and it's went through the vocal cord ما في مشكلة. It's enough do you think؟ يعني هل يا ترى I would guarantee إنه 100% it's in the يعني it went through the vocal cord ما راحت مطرح تاني مثلا؟ إذا هون هيدي مثل ما حكينا مثل it's a group of bundles يعني عدة intervention لازم شيك عليها أو لازم شوفها اللي بتأكد لي إنه أنا فعلا أنا عملت intubation مضبوطة للمريض. أول شغلة فإذا من خلال النظر direct visualization مش إنه عم بجرب أحط التيوب مثلا ما عم بقدر there is pressure or I cannot introduce وإلى آخره. لا أنا مجرد ما حط التيوب and went through the vocal cord فإذا I am يعني ما راح أكون pretty sure 100% but at some point I could see that إنه this is one of I achieve one of the bundles for intubation ألا وهي الفيزوال visualization. وطب حتى كمان أنا you remember that I'm still أنا ما خلال هالوقت أنا ما في قطع الأكسجينيشن عن المريض. إذا at the same time I could see a clear and equal bilateral breathing sounds on auscultation of the chest. يعني مجرد محطة بيكون في عندي a breathing sounds bilateral. شو يعني أنا حطيت أكيوب بعطي oxygenation both side of the chest is moving عم يطلعوا مع بعض بينزلوا مش one side is moving وفي عندي breathing sounds مش abnormal breathing sounds عم بسمع أنا breathing sounds اللي هي through the auscultation والدياي. فإذا auscultation والدايركت فيزواليزيشن لتست المريض كمان just another indication. طبعا اذا كان المريض مثلا مثل ما حكينا الفيديو حطيناه تيوب راح على الابيجاستريوم مثلا، ما راح على ذا فوكال فود على التراكير على الابيجاستريوم، ما راح يكون في عندي تشست رايتس وراح يكون في عندي abnormal sound. اوكي، فاذا بده يكون في عندي abnormal. الشغله الثالثه absence of sound on the epigastrium equal bilateral chest slide ventilation. انا بس اعطي المريض الفنتيليشن بالامبوجين نشوف انه there is equals movement of the chest. absence of stomach contents in the tube، يعني كمان كثير مهم مثل ما حكينا، كثير مهم شيء انه ما عندي and ما في عندي يعني gastric regurgitation او gastric contents عم يكونوا بالتيوب. improve saturation with proper waveform. شو يعني improve saturation؟ كيف في اعرف بهالموضوع؟ what do you mean by improve saturation with a proper waveform؟ بتعرفوا كمان المريض، يعني كل المريض الاكسجين ساتوريشن كيف بنشوفها على البلس اوكسيمتر مونيتورنج. اوكي، اذا بده يكون في عندي بروبر ساتوريشن. يعني بده يكون في عندي انا بتشيني وحده من الاشياء المريض ليش راح انتوبيشن، لانه في كثير اسباب منها مثلا يكون ديساتوريتد او هايبر كابنيا والى اخره. طيب انا وقتها بشوف في عندي امبروف بالاس بي او 2، امبروف بالساتوريشن، فاذا it's a good يعني يعني I have a good saturation or SpO2 reading والوصل waveform، فإذا it's a great indication إنه المريض يعني it's improving. يعني أنا الإكسبكتيشن من الإكسبكتيشن يعني إنه الساتوريشن it will improve. إذا ما عملت improvement بالساتوريشن فإذا I have a problem somewhere. فإذا مثل ما حكينا هيدي كلياتها indication تساعدني تحط تشيك وتأكد إنه المريض he has a proper intubation. طيب الان تايتل شوفت ان تايتل سي او 2 ديتكت، هي البيز لاين هي شلونها بيربل but it could turning as a gold. هذا فرجيكم اياها على الصورة. I will show you again. إذن هي it's purple مثل ما شفتوا. This is very important measures تعرف إنه tube in place. إذن this is very important measures to make sure or to double check إنه the tube is in place. اللون purple as we see. إذن إيش هو الإكسبكتيشن من هنا؟ هي البيز لاين، فإذا المفروض تكون to turning as gold. إذا يعني ال color exchange to gold means we are doing good. والنقطة الأخيرة واللي هي جدا مهمة ألا وهي الأوبتيمينج تشيست إكس راي. شيك إنه بورتابل تشيست إكس راي. واي؟ ليش حسب رأيكم؟ اذا اخر شيء هلا مش immediately مش دغري باللحظه ذاتها، يعني هودي في اشياء سي اوتو ديتكتور والامبروفمنت والساتوريشن والتشست رايس، هيدي اشياء اوكي يعني يعني كثير مهمه اعرفها. يعني هيدي بتعطيني مثل ما بيقولوا الاشياء الشبه اكيد انه I am doing well لانه التيوب ان بليس. في شغله كثير مهمه مثل ما حكينا at the end هي البورتابل اكس راي. اجي واعمل اكس راي للمريض انا بتبين لي التيوب. بعتقد شفتوها يمكن بالمحاضرة الأولى مع إنه كيف how to make sure إنه التيوب is empty. مثلا كمان هيدي من الأشياء اللي يعني فإذا I have portable X-ray هي at the end to be done بتشيك لي إنه المريض بعد ما يكون انتبه. طبعا هلا ما راح أعمل أنا تشيست إكس راي مريض بعرف إنه الساتوريشن مش عم تتحسن وما في تشيست رايس، بعمل الإكس راي. يعني تشيست إكس راي مثل بيقولوا هو يعني التأكيد الأخير. أوكي، ما بروح أعمل أنا تشيست إكس راي لمريض السي او 2 ديتكتور ما تغيرت والساتوريشن ديز نوت امبروف وما شفت أنا ما عندي تشيست برايس ولا او عندي تشيست از moving from one side وعندي abnormal sounds يعني كلياتها. بس هو وقت انا كل هذه الاشياء يعني بعملها وبينت عنده انه اتس اوكي، ساعتها بلجأ على الموضوع الاخير اللي هو التشيست اكس راي انه ينعمل just to confirm that the tube empty. اوكي، اذا في اي سؤال عن الرابid sequence intubation؟ إذا نرجع نعيدها إن باختصار، نحن مثل ما حكينا it's very important to closely، هذا عم نتكلم عنه خلال المونيتور monitoring of the patient or closely مراقبة المريض. مراقبة المريض عم بعرف كيف بدي أشوف ليش بدي راقبه. أي نوعية من المرضى تحتاج المراقبة؟ هي المرضى اللي بتكون in a highly critical condition. ليش براقبها؟ إنه المرضى ما بيكفي إنه راقبها بس، بدي راقبها وكون ready for any intervention. يعني مريض كيف بدي اعمل انترفنشن بيز على ايش؟ على على يعني تقديرات معينه؟ لا، بدي يكون في عندي بيز لاين معين شيء قدامي. كيف وشو؟ مفهوم من خلال المونيتور مينلي. المونيتور بعمل هيموديناميك مونيتورنج وممكن نشوف الاي سي جي. تكلمنا عن الهيموديناميك بشكل كتير وتكلمنا عن الاي سي جي كيف نعمل المونيتورنج وكيف نتصرف. اهم شيء ما بيكفي انا مونيتور بس، I need to take action. واتكلمنا كمان انه بحال المريض صار في عنده يعني مثل ما حكينا المريض انا عم راقبه باين عندي اي سي جي ابنورمال، طيب انا اتصرفت، اعطيت ميديكيشن، او مريض هي فيل داون، او مريض عنده والى اخره وعم شوف انه عنده decrease level of consciousness، بدي اخذ اكشن. ما بدي يكفي بس راقب، مونيتور بلس اكشن. شو هي؟ وحده من الاشياء اللي حكينا انه المريض كودد، بدنا نعطيه شوك، بدنا نعطيه سي بي ار، بدنا نعطيه ميديكيشن. طيب ومريض كمان ما ضروري يكون كودد، يمكن مريض يكون عنده decreased level of consciousness، عنده واطي، عنده saturation يعني والى اخره. بضطر وقت يكون rapid sequence intubation بضطر حط المريض على التنفس الاصطناعي because he cannot maintain his airway، لانه ما بيقدر he cannot maintain his airway، بضطر حطه على مكنه التنفس الاصطناعي. وما طيب وقت عم نحطه على rapid sequence intubation او intubate the patient it needs preparation for a minute. أهم شيء إنه يكون عندي كل شيء ready وأمشي بستبس من ال preparation of material re-oxygenation، والمريض بده يكون sedated، وبساعتها بعمل الانتوبيشن. وبس أعمل الانتوبيشن وشيك إنه المريض is okay، بدي أعمل confirmation إنه it's in place والله ما راحت أنا تحت. أوكي، any question؟ تحبوا تسألوني قبل على بريك الغداء وبريك الصلاة ونرجع على الساعة 1 إن شاء الله. إذا في أي سؤال بتحب تسألوني قبل ما نروح على البريك فور صلاة تايم اند لانش بريك، والساعة 1 إن شاء الله بتكونوا مع السبيكر الآخر بعد الظهر. أي سؤال؟ If you have any question I am ready to answer you now. طيب إذا ما في أسئلة فإذا الحين وقت الغداء ووقت الصلاة، وبنشوفكم إن شاء الله على الساعة 1. فإذا الحين بريك لحديت الساعة. الله يعطيكم العافية جميعا، شكرا لكم، ونشوفكم إن شاء الله بخير وسلامة على الساعة 1. إذا بريك لحديت الساعة 1، ولو سمحتوا الكنترول بس حطوا إنه بريك للساعة 1 عشان الكل يعرف إنه وقت البريك. ونشوفكم إن شاء الله الساعة 1.
Good afternoon, everybody. الصوت واضح عندكم؟ Do you can hear me? Okay, and you can see the slide team steps for rapid response. Okay. طيب نقول بسم الله الرحمن الرحيم. Good afternoon everybody. We will start our second half of the day. We'll talk about a rapid response team in order to respond for patient emergencies anywhere in the hospital. Okay. بتكلم عن فريق التدخل السريع. هو يختلف عن فريق الكود جرين أو الكود بلو حسب وضع المستشفيات. اوكي، يعني the rapid response is before arrest. okay, and the code team is after patient is arrest. طيب, what is rapid response team? The rapid response system is the overreaching, okay, or overarching structure that coordinates all teams involved in a rapid response call. فلما نتكلم عن ال rapid response system, it includes all the teams that responds to patient emergencies. It includes the septic campaign or septic response team, stroke code team, adult and pediatric code teams. all together they call them rapid response systems. طيب, the team steeps the Agency of Healthcare Research and Quality's curriculum and materials for teaching teamwork tools and strategies for health professionals. Okay, this model is of teams steeps is for rapid response systems. طبعا this presentation is entirely from the Agency of Health Care and Research and Quality, okay, as you see, without any change for the copyrights. And I always love to use presentations that are internationally approved and validated. Okay. طيب, what is the rapid response team? The rapid response team has several parts. One of them is being the rapid response teams. The RRT, known by some as medical emergency teams, is a team of clinicians who brings critical care expertise to the patient bedside or wherever it is needed. Okay, so this is the idea of rapid response teams, is to bring critical care to patients outside the ICU in case of patient emergencies. And before, hospitals used to use what we call it ICU consultations, still existing, but rapid response teams is responding to patient parameters that are beyond the capacity and the capability of the unit, and nurses and doctors in the floors. So you need more acute scenarios. فإذا فريق التدخل السريع هو عملية نقل الرعاية المركزة من العناية المركزة إلى جانب المريض في حال احتياج المريض لهذه الرعاية بشكل طارئ. Okay, فهذه هي فكرة rapid response team, is bringing the critical care expertise to the patient bedside. Why should we care? ليش احنا مهتمين بهذا الموضوع؟ People die unnecessarily over day in our hospitals. Okay, يعني في ناس بتموت لأسباب تافهة. طبعا الأعمار بيد الله، لكن لما تراجع سبب الوفاة هتلاقي إنه بعلم الله إنه يعني كان يجب أن يتلقى المريض رعاية أفضل. It is likely that each of you can provide an example of a patient who, in retrospective, should not have died during his or her hospitalization. Okay? يعني لو نيجي نراجع احنا تاريخنا في الرعاية المركزة في المستشفى، يعني في مجموعة من الحالات انه المريض لم يتم تقديم الرعاية بشكل جيد مما ادى الى الوفاة. there are often clear early warning signs of deterioration. ودائما في هناك مؤشرات سابقة ما قبل إنه وضع المريض يتطور ويتدهور بشكل سيء. Establishing an rapid response systems is one of the Joint Commission's 2008 National Patient Safety Goals. اوكي يعني هذا احد الاسباب لكل المستشفيات اللي تسعى للاكريديتيشن اجباري انه يكون في هذا المستشفى rapid response systems. Teamwork is critical to successful rapid response and the evidence suggests that rapid response systems works. اوكي طيب do it. Number of cardiac arrests before rapid response team. This is a research study was done earlier in 2003. Okay, has dropped from 63 to 22 after the application of rapid response teams. Death from cardiac arrest dropped from 37 to 16. Number of days in ICU post-arrest dropped from 163 to 33. Number of days in hospital after arrest dropped from 1,363 to 159, and inpatient death dropped from 302 to 220 after the application of rapid response teams in a research study. Does the rapid response team works? Yes. There is 50% reduction in non-ICU arrests. يعني outside the ICU, because when you go rapid response, you go outside the ICU. Reduces post-operative emergency ICU transfer by 58% and death by 37%. Reduction of arrest prior to ICU transfer 4%, okay, versus 30%. 17% decreases in incidences of cardiopulmonary arrest, okay, per 1,000 admission. When you respond to patient emergency earlier before the patient develop an arrest, definitely you can decrease the rate of arrest and decrease the rate of ICU admissions. The National Quality Safe Practice have identified the response systems as a chief example of a team intervention serving the safe patient practice elements, okay, of team training and team interventions. So it's not a new idea. Having a rapid response teams has been initiated in 2003. يعني قبل 20 سنة تقريبا، okay, تم تطبيق الفكرة. وإن 2006 the National Quality, okay, Forum in the United States updated their safe practice recommendation and mandated the rapid response teams. Also, the Joint Commission, which is the JCIA, have amended a standard in 2008 to improve recognition and response to change in patient condition as one of the international safety goals. So having a rapid response team in our hospitals is something mandatory by accreditation, and it's part of our safe practice toward our patient. إذا من متطلبات الاعتماد الدولي إنه يكون عندك نظام استجابة سريع لتغيرات حالة المريض. اوكي مو بس كود بلو and كود جرين. You have to have something before arrest. طيب implementation. When implementing rapid response systems, the institution for healthcare recommended engaging senior leadership. فأنت عشان تنجح في تطبيق الرابid response systems لازم يكون الإدارة العليا هي من يشرف على تطبيق هذا الفريق. Identifying key staff for RRTs, وغالبا يكونوا ICU nurses, respiratory therapists with ICU experience, and ICU doctors, okay, or senior medical doctors with advanced life support certificate, and they have ICU sub-training. Using a structured documentation tool in all the process from recognition, activation, and during the rapid response activity and post-rapid response activity, all this must be documented. You can document it on paper, you can document it on computers. Establishing a feedback mechanism. For every single case, you have to have a debriefing and you need to send the feedback about the outcomes. So a quality management and data collection system is important. measuring effectiveness. Okay, and we always say what you cannot measure you cannot manage. يعني إذا أنت ما تقدر تقيس مستوى نجاحك فأنت لا تستطيع أن تحسن من الأداء. Okay, rapid response system can be customized to meet your institution need and resources. فتقدر إنك أنت تخترع فريق يناسب احتياجاتك وقدرات الفريق الموجود عندك. Okay, طيب the rapid response system structure. Okay, you need responders. Okay, those responders are the people who go and see the patient. Okay, and they have to be supported by administration. Okay, which is the support mechanism, and you have the activators, and the activators are the clinical treatment. Okay, the clinical treatment, and also you should have a quality improvement. You should have a quality improvement. But this is how we build our rapid response. Like the activators can be floor staff. وكلمة activators مين هم الناس اللي يطلبوا فريق الرابid response لما حالة المريض تتدهور. Okay, they can be a floor staff, they can be technicians, it can be the patient himself, a family member, any specialist, anyone sensing that the acute deterioration. Okay, so rapid response teams can be activated by any person who is educated to activate the rapid response team, because we are talking about certain criteria to activate. Okay, طيب احنا قلنا أول the first part is the activator, the second part is the responders. The responders come to the bedside and assess the patient situation. Okay, responders determine patient disposition, which could include transfer the patient to another critical care units like ICU or CCU, a handoff back to the primary nurse, primary physician if the patient stabilized, and receiving the treatment plan if the patient is going to be activated as an acute patient, and the patient should receive a critical care before he transferred to the ICU. Okay, so activators may become responders and assist in the stabilization of patient. يعني which means if you are a primary nurse and you activated a rapid response team, you can be helping in inserting the IV lines and starting IV fluids, preparing medication and give it to the patient. So initially you start as an activator, then you become part of the responding team in order to stabilize the patient. Because in majority of hospitals, in their policies, it dictates that rapid response team is not a replacement for a primary team. Okay, still the primary team is responsible for the patient, but the patient will become under responsibility of critical care and rapid response teams if patient is going to be transferred to the ICU. Okay. طيب activators and responders. Activators are responsible for calling the responders if a patient meets the calling criteria. فوظيفة الأكتيفيتر إنه يطلب فريق التدخل السريع إذا المريض طابق معايير معينة. Okay. Responders must reinforce activators for calling. Okay. Why did you call versus thank you for calling. What is the situation? الحين okay, there are no bad calls. يعني للأسف الشديد، وما أعرف إذا أحد منكم يواجه هذه المشكلة، إذا عندكم rapid response team, when you call them, some of them they will ask you why you are calling. In fact, the rapid response team must say thank you for calling. هلا للأسف الشديد بعض الناس اللي غطوا فريق الرابد ريسبونس لما تتصل عليهم الممرضة أو الممرض أو الطبيب المعالج بالطابق العادي، أول سؤال يسأل يقول له يعني أنت ليش تتصل؟ طب ما هو أنا أتصل لأنه أنا عندي كرايتيريا، وأنت وظيفتك إنك تجاوب على هذه الكرايتيريا. أوكي؟ فرابد ريسبونس تيم is responsible to reinforce the activators. So you should not blame them for calling. You should thank them for calling, because there is no bad calls. يعني ما في اتصال على الفاضي، على الأقل تيجي تطمن على المريض. اوكي، يعني مو الهدف اني اشغلك. السبورت، الرابid ريسبونس تيمز يحتاجوا لسبورت. So the quality improvement and administration، نحتاج دعم من فريق من إدارة الجودة ومن الإدارة العليا. The quality improvement team supports activators and responders by reviewing RRSs اللي هي Rapid Response System Events and evaluating data for the purpose of improvement. اوكي، ففريق الجودة يراجع جميع الحالات من أجل تحسين التوثيق وتحسين الخدمة. وتhe administrators team of the rapid response systems brings organizational resources, support and leadership to the entire rapid response systems and ensure that changes in processes are implemented if necessary. فمن واجب الإدارة العليا إنها تدعم الرابid response teams. اوكي، طيب. Teams work and rapid response systems. The rapid response teams has these barriers of effective care. دائما الرابid response teams يواجهوا هذه العقبات. اوكي، طيب. The first، اوكي، conflict اللي هو الصراع. اوكي، second lack of coordination، في سوء تنظيم. distraction اللي هو التشويش. اوكي، fatigue تعب، الورك لود لانه احيانا يكون فقط one rapid response nurse وكان في 3 calls at the same time. اوكي، misinterpretation of cues، فغالبا بدل ما احنا نستخدم لغة واضحة يصير في عندنا لغة مشوشة قابلة للتأويل بشكل خاطئ. اوكي، inconsistency in team membership، يعني مو دائما انك تحط اشخاص يحملوا تخصص يناسب. lack of time because of a lot of work and sometimes excessive amount of documentation. lack of information sharing. okay، يعني the respiratory therapists have information that did not share with the nurse did not share the information with the doctor, or the doctor is putting orders or he's calling the primary teams without feedback to his team. Okay, طيب. What are the necessary team skills? Okay, we need to have knowledge, we need to have attitude, and we need to have good performance. And that requires skills. Okay, and you need to put together mutual support, situation monitoring, leadership, and communication. So those are necessary things for team success. Inter-team knowledge support effective transition in care between units. This is the most important thing, because when you call the rapid response team, you are providing higher level of care to your unit. It is prerequisite for transition support. Okay, يعني you need to know what are the limits of your services and what are the limits of your responsibilities. حدود المسؤولية وحدود المكان اللي تغطيه لازم تكون واضحة. Consist of understanding the roles and responsibilities for each team within the rapid response system. حتى داخل الفريق كل واحد وظائفه واجباته مكتوبة. اوكي، مكتوبة بجايد لاين وبوليسي واضح. In the inter-team knowledge, the activators need ICU requires, administration requires, and patient needs. Okay, so the activator needs, the ICU requirements, the administration requires, and the patient need. For responders need and ICU requirements. Okay, so the responder thinking to provide patient to ICU, and the activator wants to push the patient to the ICU. So that's why the activators, the responders, the administration, and the quality improvement are all together considered a team. Okay, so in order for your rapid response team to be successful, you need to identify your activators and you give them a criteria to activate. You have to prepare your responders and they have to be qualified to respond. The administrator must provide training and supplies, and the quality improvement must read all the activities in order to improve the care. Okay. Transition support, boundary spanning, requires inter-team knowledge, combined monitoring transition in care and providing back up behavior when needed. Okay. يعني activators become responder. And sometimes the nurses, they activate the rapid response team and they disappear. They go and care for other patients. This has to be very clear in the rules. Okay. We have to manage the data and monitor the transition and educate the staff and ensure data recording and assist in the role orientation. Because if you are initiating a rapid response team or a new staff of rapid response team is joining, in training and knowledge is the key, is the tool. Okay. Example of RRS activators call responders using a pager. Who are the responders? The activators, they just call, but who's gonna respond? You have ICU physicians, ICU charge nurses, nurse practitioners if available, rapid response system coordinator, transportation service for pediatric units, okay, chaplain office, security and respiratory therapists are also included. In some hospitals, they make a medical response teams for adult and same for pediatric, okay? Training, include direct teaching model on rapid response and practice using situation background assessment recommendation, okay, which is SPAR. Online training modules, single discipline training scenarios, okay. إذا من الضروري جدا إنه كل إنسان يتم تعيينه في مجال الرابيد ريسبونس إنه يتلقى تدريب واضح، والتدريب يكون على الدوكيومنتيشن، على الاسسمنت والدياجنوسيس والانترفنشن والدوكيومنتيشن والكوميونيكيشن. ف those are the most important keys. Data collection includes reporting. Who called the response team and what criteria you use? Who responded and what is the time frame? Because you have to respond within 15 minutes. What was done for the patient and what are the 5 diagnoses seen in the rapid response systems, okay? Activators call responders using an overhead pager or a phone whatsoever. Family members are considered activators. طبعا هذه الخطوة لحد الآن لم يتم طرحها في مستشفيات المملكة، إنه الفاميلي they can activate a rapid response. يعني I don't know any hospital here in Kingdom allowing the family to be an activators. Responders include nursing staff, respiratory care staff, and ICU staff. Okay, وغالبا يكون ICU nurse, respiratory therapist from the ICU, and an ICU doctor. طبعا ال ICU doctor ممكن fellow or consultant or assistant consultant. Okay. طيب. Training. How do you train your RRT teams? You train them in class sessions, in simulation centers, and interdisciplinary training in the same location. Data collection, event debriefings, and task-oriented checklist by the role. Okay. طيب. Example, okay, for a nursing tasks completed. Check the patient pulse, yes. Obtain vital signs, place pulse oximeter, access patient IVs. Okay, this is nurse responsibility. Okay, respiratory therapist task, assess the airway, count the respiratory rate, assist ventilation, check the patient pupils. Okay, for example. So you need to have a task list for every responder at the bedside when the patient is, when the RRT is activated. فمن الضروري جدا إنها تكون المهام والخطوات واضحة جدا بالنسبة لكل شخص. اوكي طيب let's identify your structure. Okay, think about the 4 components of rapid response systems: activators, responders, quality, and administration. Who are the activators? Okay, what are the alert criteria? How are responders called? What do activators do once and responders arrive? Okay. Who are the responders? How many responders arrive to a call and what is each responder role? Okay. طيب, what are the common challenges facing your rapid response systems? Are there challenges during patient deterioration, system activation, patient handovers, patient treatments, and evaluation of the response team? Okay, those are important items. طيب. So, we have detection, activation, response, and disposition, and at the end we do evaluation. So in case of a training scenario, you need to apply these 5 phases of rapid response systems. Okay. So what are the 5 phases of rapid response team? Activation, it is detection. When you detect if the patient meet the criteria, then you activate the rapid response team. The rapid response team assess and stabilize the patient or disposition the patient to the critical care. And at the end, we make an evaluation. Okay. Detection, activator see signs of acute deterioration before actual deterioration. Okay. And he keeps situation monitoring. Detection, the status of the patient. Okay. Use your institution detection criteria. وغالبا the detection criteria are very clear. It is about tachycardia or bradycardia, tachypnea or bradypnea, desaturation, hypotension, decreased level of consciousness, or seizures. Okay, those are the most common criteria to call. Okay, where can detection occur? Detection can occur from a variety of sources or consents. Okay, يعني it's either by observation or by vital signs. Okay. The rapid response activation, communication tool, and strategies. You can use what we call it SBAR. Okay, the SBAR provides a framework for team members to effectively communicate information to one another. Okay, communicate the following information: situation, which is S, what is going on with the patient. Second, background, what is the clinical background or context. Assessment, what do you think or I think about the problem, and recommendation and request. طيب, لو جينا نحط عليها example. Okay, هنا when you call you will say good afternoon, my name is Ahmed, for example. Okay, I am in my patient room and I notice that patient have changes. Okay. This patient has a history, or he's a 70-year-old, for example. He has a history of end-stage renal disease, and the patient has not have dialysis for the last 2 days. I noticed that he has rails on his breathing on my assessment, and his saturation dropped to 81. I applied oxygen for him, 6 liters of oxygen via face mask, and now the saturation is 90. Okay, patient is lethargic. My recommendation, I activated the rapid response team, so please arrive to see the patient. Okay, so this is how we apply the SBAR. طيب. Response assessment stabilization. Responders analyze patient condition, attempt to stabilize, and responder assessment and stabilization. What does that mean? I arrive to a patient is hypotensive. He has an IV line, or I have to insert an IV line, and I started rapid infusion of normal saline. At the same time, while I am giving the infusion, I am calling my team members. I am calling the respiratory therapist and the doctor for more intervention. The leadership situation monitoring must, happen all the time. And how do we do the monitoring? We use tools and strategies for leadership, like brief huddles, or we can check back and call out, and we can do what we call it task assistance, COS. Okay, so you always need to discuss, the situation. You have always to discuss the situation and anticipate outcome and likely contingencies. You need to assess resources, and you have to express your concern. For example, a patient is deteriorating. He is breathing fast. The doctor is just giving him Lasix and increase amount of oxygen, but the patient is not improving. In this case, you have to speak up. You have to speak up. I am concerned and I am uncomfortable, or this is a safety issue, stop. So always when you feel that situation is not optimal for the patient, you always need to show your concerns. For example, and I'll give you example from real life. Now we arrive to a patient who is unconscious, GCS is 7/15, but patient respiratory rate is stable, saturation is 98, blood pressure is 140/80. So everything is stable for this patient, except for GCS of 7, and you need to make a jaw thrust in order to open the airway for patient to breathe. The activation of rapid response happened, and doctors came, and the doctor was evaluating the patient, and he said there isn't a major concern except for decreased level of consciousness, which is like unclear. In this case, what shall I say? I said, I am concerned that this patient GCS, and by the criteria, the patient is meeting the criteria for intubation, because any patient with GCS below 9 should go to the ICU, and he has to be provided with protected airway, And I said, I am uncomfortable to keep holding the patient jaw in order to maintain his airway patent, because you cannot make a jaw thrust for hours. You have to find another solution, And I said, you have to stop. And this is not safe situation for the patient. We cannot leave the patient like that. Patient must be intubated, and because of unknown decreased level of consciousness, this patient must go to a CT scan. The doctor, he said, I will call my consultant. Then he went and called his consultant, and the consultant, he said, activate the code team, intubate the patient, send him to CT scan, and bring the patient to the ICU. So because I said I am concerned because the patient level of consciousness is not optimum, and I am not comfortable to leave the patient in this situation, and I said we have to stop, we have to do something. So this is an example how we are using the CUS words. The patient disposition, communication tools and handovers, SBAR, I pass the button. طبعا هذول tools هتكلم عنهم. The patient will be transferred from the floor to the ICU. Patient disposition can refer to a number of decisions: transfer the patient to another unit, a handoff back to the primary nurse, primary physician if the patient stabilized, a handoff to a specialized team, like cardiac team or code team or a stroke team, because sometimes you as a rapid response team, you activate the code team and the patient will be under the code team responsibility. And a revised plan of care. All that must be clearly documented, okay? The rapid response transition, I pass the baton this is هذا اختصار لمجموعة من الكلمات. Introduction, introduce yourself and your role. Job include patients. Identifiers for patient, which is name, age, sex, location. Assessment, present chief complaint, vital signs, symptoms, and diagnosis. Situation, current status, circumstances, including code status, level of uncertainty, recent changes, and response to treatment, okay? Safety, you have to inform about critical lab values and report socioeconomic factors, allergies, alerts like fall and isolation, okay? Background, comorbidities, previous episodes and current medications and family history. Action, what action were taken or are required, okay? Provide brief rationales. Timing, level of urgency and explicit timing and priorities. Ownership, who is responsible, okay? Nurse, doctor, team, including patient family responsibility. And next, what will happen next? Anticipated changes. What is the plan? Are there contingency plans? Okay, so all those questions, all those steps must be documented clearly. Okay, طيب. The evaluation of the response or the quality of care. Brief occurs right after the event and are conducted by the responders. Was the communication clear? Was the roles and responsibilities understood? Situation awareness maintained? Workload distribution was fair? Did we ask for or offer assistance? Were errors made or avoided? What went well? What should change and what can improve? This is what we call it debriefing, or it's a quick evaluation of the situation and at the end of the rapid response, okay? System evaluation, okay? Since making review sheet, how did the activators and responders act to the situation? And when looking at the big picture, are there any patterns or trends? Okay, what can go wrong? What are the consequences? How do things go wrong? How likely are they or can go wrong? Okay, usually we apply the failure mode and effect analysis system. Okay, طيب. Let's look back at our examples. Exercise 1, using the scenario provided, identify the 5 phases of rapid response and what tools and strategies we use during the phase. طيب. In phase of detection, okay, in phase of activation, in phase of response assessment and stabilization, indisposition and evaluation, okay? So this is supposed to be exercise, okay? And we will go through scenario, okay? Fine. I want you to share with me, please, these scenarios, okay? And there is something important I want to ask you about, if you don't mind, okay? Is the rapid response team concept clear? Do you have any experience with rapid response teams in your hospitals? عندكم خبرة مع موضوع الرابid response teams؟ هل يوجد في مستشفياتكم rapid response teams? Do you have rapid response teams in your hospitals? أحد عنده تجربة مع rapid response team either as a activator or responder? طيب ما علينا. اوكي. البيشنت descriptions. Sam is a 75-year-old man with a history of diabetes and congestive heart failure. He has an 80 packs years smoking. Okay, history يعني بدخن 80 باكيت سيجار في السنة. He was admitted to the medical unit yesterday. يعني دخل على قسم الباطنية أمس. with a diagnosis of pneumonia. Okay. During the last respiratory assessment 4 hours ago, his pulse was 80 and regular. His RR was 26. His SpO2 was 92 on 2 liters. Okay. Per minute by nasal cannula. He was sitting in a high Fowler position, intercostal retraction and used of accessory muscles were noted. Current medications are Lasix and Dunep, propranolol and antibiotics. The patients are in activated rapid response when Sam's family arrived and found him lethargic and confused. طيب, initial scenario conditions. Patient is in bed, semi-Fowler, but slumped over, bilateral wheeze. Okay. His heart rate was 124, his respiratory rate was 38, and his SpO2 was 85%. Okay. طيب. The scenario branch points. If oxygen not applied, oxygen will continue to fall. RR and heart rate will increase. If nebulization not given, increase signs of distress. If ABG not drawn, he will go into respiratory arrest. Okay? If bipipe not applied or ABG interrupted incorrectly, the patient might go into respiratory arrest. Okay? طيب. In this situation, and I always ask the first question, what is your priority? Okay? For this patient. إيش أولوياتك في مريض عنده نمونيا، عنده تكبنيا، وعنده desaturation. Okay? Suppose you are the primary nurse in a floor. What do you think you should do in this situation? إذا كنت أنت الممرض المسؤول عن هذا المريض، إيش أول خطوة بعملها؟ ألو؟ في صوت ولا ما في صوت؟ أنا ما أشوف في أي ريسبونس. هل صوتي واضح مسموع؟ طيب، شكرا يا رنا على الإجابة. لكن هل هذه الحالة واضحة بالنسبة لكم؟ هذا مريض موجود بالفلور، المريض عنده نمونيا، مدخن. أوكي، عنده نمونيا ومدخن. وفي هذه الحالة أوكي the nurse activated the rapid response. This patient has tachypnea وhas tachycardia وhe has desaturation. Okay. وعنده bilateral wheeze. طيب what does this patient need now؟ احنا the patient are inactivated the rapid response team not on this parameters لأنه at this time his heart rate was 80. It does not match the to activate the rapid response team criteria. Rapid response criteria for tachycardia in some hospitals is higher than 120, and for respiratory rate more than 28, and saturation if it is below 90. Okay, or when oxygen requirement is more than 8 liters. For this patient in this time, which is 4 hours ago, was considered stable. Okay, يعني مع some compensatory sign. لكن لما اجوا الاهل, okay, when the family arrived, the patient was lethargic, يعني في decreasable consciousness and confused. The patient has tachypnea, tachycardia, and desaturation. Okay, and he has normal airway resistance, يعني he doesn't have airway obstructions. Okay, in this case, can this patient managed at the bedside or cannot be managed at the bedside? If we give patient nebulization, if we put the patient on high flow nasal cannula or BiPAP machine, definitely the patient will improve. Okay, definitely the patient will improve. So, increasing nebulization, chest physiotherapy, administering bronchodilators, okay, can help this patient to improve. But if the patient did not improve, definitely the patient need to be transferred to the ICU. Okay, as you see, this patient is deteriorating and his situation is beyond the capability of the floor care. He requires to have much more acute care. Okay, طيب scenario number 2, a 34-year-old female with acute lymphocytic leukemia after 3rd cycle of chemotherapy. Patient is shivering and sweating. She's lethargic. Okay, طيب this patient has 142 as a heart rate, 33 respiratory rate, blood pressure 82/43, temperature 39, and saturation 94. Okay? What situation do you think this patient is facing? إيش هي الأشياء اللي جالسة تواجهها هذه المريضة؟ What is your priority? Is your priority saturation, or your priority is blood pressure, or your priority is fever? Okay? طبعا احنا as medical teams, healthcare providers, we prioritize our care according to ABC. But the patient is airways maintained, she's breathing fast, yes, but she's saturating, but her blood pressure is low. So my concern here, this patient is matching the criteria of sepsis, okay? She looks sepsis, because tachypnea, tachycardia, hypotension, and fever are 4 signs of SARS, okay? And those 4 criteria meet the criteria to activate rapid response team. So the priority is to start IV fluid, and the immediate action is to activate the rapid response team. And if you are a rapid response team, you will focus on improving perfusion by improving blood pressure, because patient is a chemo patient with ALL. She might have anemia, so we need to consider transfusing blood in order to improve oxygenation, okay? Of course, you need to send a VBG or ABG to look at lactic acid and to look at hemoglobin to see the severity of shock. And if patient did not improve on fluids, you might need to use vasopressors. And in this case, patient needs to go to the ICU. Okay? طيب. Patient lactate was found 4 and hemoglobin 6. Okay? In this case, the patient also was given 2 liters of normal saline and ringer lactate, but MAP is still 52. 4 is septic shock, hemoglobin is severe anemia, and 52 is considered a very low blood pressure after a fluid challenge. In this case, patient disposition should go to the ICU. Okay. Case scenario number 3, a 64-year-old male, history of end-stage liver disease, cirrhosis, and ascites. GCS is 5/15. Heart rate is 54. Blood pressure is 110. Respiratory rate 34 shallow, and saturation is 80. Priority and immediate action. In this case, we should activate a rapid response team, and the expectation from rapid response team is to intubate the patient. So a code should be activated, and patient must be electively intubated to protect the airway and has to be transferred to the ICU. But in these scenarios, usually patient code status is discussed, okay? Whether this patient is a transplantable or non-transplantable patient. And in this case, a patient is non-transplantable, يعني ما يحتاج أو لا تستطيع إنك تعمل له عملية زراعة كبد. ممكن إنك تطلب إنه المريض ينحط على نو كود، أوكي؟ على نو كود. طيب scenario number 4, 65-year-old male, history of heart failure, chronic AF and hypertension, sudden right-sided weakness, facial deviation, and aphasia. Okay? In this case, this patient is showing what? والله أنا كنت حاب حد يشارك معي، okay? بالإجابة. I would like somebody to participate in answering. If you are a nurse or a doctor at the floor and you notice that this patient with this history having right-sided weakness, facial deviation, and aphasia, you will think that these are signs of stroke, okay? In the stroke, if patient is vitally stable, okay, brain takes a priority, okay? If ABC are controlled, brain takes a priority. So that's why establishing deterioration time is important. If it is less than 3 hours, patient should, of course, the floor nurses will activate the rapid response team because this is considered new neurological deterioration, okay? So the action will be activate the RRT, and the RRT, the IC doctors are going to activate the code stroke if you have a code stroke, or at least this patient will require a neurological consultation urgently in order to establish acute stroke management, which will require initially stabilize patient vitals, make sure blood pressure is stable, controlled. We send the patient for an urgent scan to determine whether hemorrhagic or ischemic stroke, okay? And the further plan, this patient might go to the ICU or to a stroke unit, okay? طيب. So this is how rapid response team is applied as a system, as documentation, and how do we deal with case scenarios. اوكي واضح؟ حدا عنده أي سؤال على هذه المحاضرة؟ Do you have any question about this presentation? If there is no questions about this presentation, we will move to the next presentation, which is hemodynamic instabilities. Okay? Right. Now we will focus on this, on types of shock, which is the situation where patient is hemodynamically unstable, okay? Shock, according to John Collins, is a momentary pause in the act of death. يعني هي عبارة عن مشروع وفاة، مشروع موت, okay? Any patient with signs of shock, he is at the risk of deterioration, okay? To die. The first criteria in determining hemodynamic instability is systolic blood pressure in patient with normal parameters. Okay? Now, a patient with a blood pressure systolic below 90 or a mean arterial pressure below 60 is considered hypotensive. But if a patient is known to be always hypertensive, like this patient reading always 160, 170, or 180 and above, any reduction in patient systolic blood pressure 40 millimeter Hg from the baseline. يعني مريض ضغطه 170 نزل ضغطه ل 120، هذا الشخص يعتبر in shock even blood pressure is normal. Okay, or he's in hypotension, sorry, at least في البداية. Okay, so shock is inadequate organ perfusion to meet the tissue oxygenation demand. So when I say that my patient is hemodynamically compromised or hemodynamically unstable, it means the oxygen supply to the tissues is affected. Okay? Hypoperfusion can be present in the absenteeism of significant hypertension. Why? Because in some shocks, vasoconstriction is happening in order to maintain the pressure. So you could have a pressure, but you don't have, but you have signs of poor perfusion. طيب. ايش هي العوامل اللي تتحكم بالكاردياك اوتبوت؟ اوكي؟ احنا نحتاج ان يكون عندي end-diastolic volume، end-diastolic volume it means the expansion, the stretchability of the heart is normal and the heart has a adequate volume. Okay, patient must be normovolumic. Okay, لازم تكون كمية السوائل في الجسم كافية. اثنين end-diastolic volume. والend-diastolic volume depend on the contractility of the left ventricle. So when the contractility of the left ventricle is not strong enough, the amount of blood that will be ejected by left ventricle every beat, which we call it stroke volume, will decrease. طيب, stroke volume needs to maintain a heart rate. So we maintain through sympathetic parasympathetic nervous system the heart rate. الآن حسابيا calculation wise, heart rate multiplied by stroke volume will always give me the cardiac output. So I should have normal heart rate, enough diastolic volume, or enough systolic volume, which is the contractility, in order to make a stroke volume. Stroke volume multiplied by heart rate will give me the cardiac output. Okay, so your patient stabilization will include the normal heart rate. Okay, so patient should not be bradycardiac or tachycardic. The receptors that are responsible to respond to adrenaline and noradrenaline اللي هم نسميهم الادرينو receptors A, R3 and A alpha. When I say alpha, I know that this receptor is in the arterial system. When it is stimulated by epinephrine, it will cause vasoconstriction, increase resistance, increase blood pressure. Okay? Beta 1 are beating heart, يعني they are in the cardiac wall, responsible to increase contractility and cardiac rate or heart rate. When you increase contractility, you eject more volume. When you increase heart rate, you increase cardiac output. Okay? How does our body know that blood pressure is low? Okay? كيف جسمنا يعرف إنه الضغط نزل؟ Okay? أو في هبوط؟ عندي شيء اسمه بارو ريسبتورز. هذه البارو ريسبتورز عبارة عن مجسات أو حساسات طبيعية. The baroreceptors are natural sensors available in our carotid and aortic arteries. Once the blood pressure drops في حال انخفاض الضغط، اوكي، هذه ترسل مسج عن طريق الأعصاب لمركز الدماغ. فمركز الدماغ يستحث الأدرينال ميدالا اللي هي الغدة فوق الكلوية من أجل إفراز الإبنفرين and norepinephrine. فالإبنفرين and norepinephrine will cause vasoconstriction and tachycardia and increase contractility, and this is going to increase the cardiac output. This was going to increase the cardiac output. This is what we call it neurohormonal arch. Once the blood pressure raised up, it can stimulate the parasympathetic nervous system and send the feedback to the sympathetic nervous system to decrease the production of the catecholamines. Okay? Why the heart is doing that? In order to deliver oxygen. In order to deliver oxygen. What do you mean by oxygen? Okay. What do you mean by oxygen? Oxygen delivery is the volume of gaseous oxygen delivered by the cardiac system. And the oxygen consumption is the amount of oxygen that our tissue extracts. So the oxygen demand is the volume of actual needed oxygen to submit for the tissue to stay alive. Okay? طيب, how do you know that you have adequate oxygen in your body? You need to maintain a normal PaO2, which is the function of the lung, and you need to maintain a saturation higher than 95 in the presence of adequate hemoglobin. Okay, remember that hemoglobin is part of arterial oxygen content. So that's why arterial oxygen content, which is CaO2, is hemoglobin times saturation multiplied by 1.34, which is the amount of hemoglobin. Normally, we need 16 to 20 mil per 100 mil of oxygen, which is equal to around 1 liter of oxygen per body, okay, volumes. You can find through Google oxygen content calculation, okay? You need to put saturation, you need to put PaO2 and hemoglobin, and then oxygen content is going to be calculated for you. But you need, of course, you need to do an ABG in order to be able to calculate the oxygen content. Okay. طيب. What will happen if you don't have adequate oxygen? Okay. في حالة الهايبوكسيا أو الهايبوكسيميا, when there isn't enough oxygen presented to the body, you will have lactic acidosis. Okay. احنا normally the oxygen is used to oxidize glucose to produce adequate adenosine triphosphate, which is the amount of energy. اوكي, فكمية الطاقة اللي بيفرزها الجسم عن طريق حرق مولكيول واحد من الأكسجين هي 36 ATP. طيب لما يختفي الأكسجين أنا حيطلع عندي اللي هو الفيرمنتيشن اللي هو التخمر السكر, وحيطلع فقط 2, اوكي, حيطلع فقط 2 ATP. في هذه الحالة اللاكتيك acid is gonna go up. When lactic acid is 2, there is cellular hypoxia, but if lactic acid is more than 4, then patient is in shock. Okay? نرجع للديفينيشن. shock is inadequate organ perfusion to meet the tissue oxygen demand. اوكي، فنقص شديد في توريد الاكسجين بسبب الهايبوبرفيوجن. اوكي، that's why the FCCS course, fundamental of critical care courses, define shock as symptoms of its cause. يعني كل نوع من أنواع الشوك حيعطيني أعراض معينة حسب السبب. لكن إيش هي مراحل الشوك؟ يمر مريض الشوك بأربع مراحل. أوكي، the patient with shock passes 4 phases. الفيز الأول واللي هي early signs map decrease by 10 from baseline اللي هو mean arterial pressure, effective compensation to the vital organs, and you will see heart rate is up. احنا دائما نقول للتيمز اللي معنا إذا شفت مريضك المين arterial pressure انخفض ب10، يعني كان الماب 70 صار 60، كان الماب 80 صار 70. اوكي، and at the same time patient develop tachycardia يعني the heart rate increased by 10، لا تفرح. اوكي، لا تطمن. don't be happy, don't be satisfied, because hypotension with tachycardia are the early warning signs of shock. اوكي، طيب السكند فيز اللي هي الكومبنساتوري ساينز، يعني صار في عندي انا اعراض دفاعيه. الماب is dropped to 15 from baseline. Patient will start to produce الكومبنساتوري هرمونز اللي هم الرينين والانتي ديورتيك هرمون للمحافظه على سواء الجسم، مع الفيزو كونستريكشن، مع decrease in pulse pressure، مع تاكيكارديا، مع دروب ام بي اتش يعني يدخل في اسيدوسز اكثر، والبيشنت صار ريستلس وابريهنسيف، يعني صار في عندي اعراض نقص تزويد الاكسجين حتى للدماغ. اوكي، هذا اللي هي الكومبنساتوري فيز. البروجريسيف فيز اللي هي مرحله التطور السيء. اوكي، الماب دروب فور مور ذان 20 from baseline، وتيشيو اورجان هايبوكسيا، حيصير عندي decrease في اليورين اوتبوت، weak pulse وسيفير بي اتش اسيدوسز، والمريض عنده صار confusion. اوكي، الريفراكتوري ساينز هنا علامات الوضع السيء، يصير في excessive cell organ damage ومالتيبل سيستم اورجان فيلير مع دروب ام بي اتش. ندخل بديكريز ليفل اوف كونشسنس، decrease urine output, high creatinine, high liver enzymes, low PTP, low platelets, prolonged PTPTT. اوكي، هذا المريض خلاص وضعه ايش؟ سيء. فيجب ان لا يترك المريض حتى يصل الى هذه المرحلة. اوكي، السيركوليشن تتكون من فلويدز وبامب اللي هو الهارت and vessels. فأني failure of these three will lead to shock. ايش هم الكاتيجوريز اوف شوك؟ الهايبوفوليميك شوك، الكارديوجينيك شوك، الديستريبيوتيف شوك. الهايبوفوليميك طبعا هايبوفوليميا اما هيموريج او لوس اوف فوليومز. الكارديوجينيك اللي هي الكاردياك فيلير، والديستريبيوتيف اللي هي بيكون فيها فازو دايليشن. ومين الديستريبيوتيف 5 انواع من الشوك في الديستريبيوتيف: السبتيك شوك، الانافيلاكسيس شوك، الادرينال كرايسيس شوك، اللهم صل على سيدنا محمد، السباينال شوك، والنيوروجينيك شوك. هذول الخمسه كلهم بيدخلوا تحت الديستريبيوتيف شوك. وفي عندي الاوبستراكتيف. الاوبستراكتيف 3 انواع: اما كاردياك تامبوناد او تنشن نيوموثوركس او abdominal aortic aneurysm. اوكي، طب الجولز اوف شوك resuscitation. انت how do you manage your patient when he is deteriorating. اوكي. هلا the most important thing in managing patient with shock with hemodynamic instability is to restore his blood pressure. اهم شيء انه احنا نسترجع ضغط الدم. اوكي. اثنين, we should normalize systemic perfusion. How do we normalize systemic perfusion? أول علامة lactic acid لازم ينزل. Lactic acid should go down. Second, patient skin must get warm. Patient pulses get stronger. And urine output started to come back. And patient level of consciousness improved. Okay? طيب. Improve oxygen delivery. وأنا عندي 3 مكونات رئيسية للأكسجين ديليفري. أول واحد فيهم good perfusion pressure and adequate oxygen in the hemoglobin. Okay? Preserve organ function. والpreserve organ function عن طريق إنك أنت تتدخل بسرعة كبيرة جدا. لأنه إذا أنت تركت المريض in case of shock حيدخل برينال failure, حيدخل بليفر failure, و in this case multi-organ damage. ناخذ أول نوع من أنواع الشوك اللي هي الهايبوفوليميك شوك. الكوزز الهيموريدج. من خبرتكم وين أكثر مريض نشوف عنده هيموريدج؟ أكثر مرضى عرضة للبليدنج في المستشفيات هم المرضى ما بعد الجراحة. أوكي؟ وأنا دايما أسأل سؤال, كيف تعرف إنه مريضك صار عنده بليدنج؟ ما تنتظر السيمتومز. كل مرضى الجراحة يكون عندهم درينز, فإذا كمية الدرين تعطيك كمية درينج عالية what looks fresh blood, it means that this patient has active bleeding inside. Okay, ننتبه. Second, vomiting, diarrhea, dehydration. Third, spacing in liver cirrhosis and burn. All those will lead to hypovolemia. Okay. طيب, في الهايبوفوليميك shock the patient will have decreased cardiac output, decreased pulse, pulmonary aortic pressure, و increased systemic vascular resistance. يعني يصير عندي المريض severe vasoconstriction. Okay. طيب, how does the body compensate for hypovolemic shock? Increase heart rate. هذه أهم شيء, إنه يدخل المريض بتاكيكارديا مع الهايبوتنشن, وإنكريز respiratory rate وبريفرال vasoconstriction, يصير في عنده برودة في الأطراف مع تضيق بالشرايين. اوكي. طيب, how do we classify the severity of bleeding? البليدنج يتصنف لأربع مراحل: class 1 2 3 and 4. اوكي. طيب, هنا السؤال, we are talking about measurable volumes. okay, measurable volumes يعني هذه الفوليومز إما measurable أو estimated. فإذا كان أنا عندي نقص في كمية الدم أقل من 750 مل, هذا يعتبر كلاس 1. اوكي. وتلاقي المريض ما عنده ولا أي أعراض إطلاقا. الكلاس 2 اللي bleeding up to 1500 لتر ونص, حوالي 30% من الانترافاسكولار فوليوم, الهارت ريت يطلع فوق 100 مع ديكريز امبلس بريشر. وفي كلاس 1 and 2 تقدر تعطي المريض نورمال سلاين او لاكتيتد رينجر and he can respond. بس you need to stop the bleeding. Okay, you have to stop the bleeder. You have to identify where does this patient bleed from. Class 3, the blood loss is more than 1500 to 2 liters, أكثر من 40% تقريبا, حوالي 40% من التوتال انترافاسكولار فوليوم. الهارت ريت يطلع فوق ال 120, صار في decrease in blood pressure, pulse pressure, والريسبيراتوري ريت يطلع, واليورين اوتبوت ينزل. بهذا الحالة you have to transfuse blood, لازم تنقل للمريض دم. اوكي. كلاس 4 طبعا الأسوأ في هذه الحالة. احنا دائما نقول اي مريض بوست سيرجري وعنده درين وهذا الدرين يطلع continuously you have to notify the surgeon immediately، خاصة إذا كان fresh blood وبرايت in color ممكن يكون arterial bleeding. اوكي. treatment of hypovolemic shock preserve hypovolemia and hemorrhage control. هاي أهم شيء، إنك أنت توقف النزف وتعطي المريض سوائل. اوكي. control bleeding and give the patient fluids. crystalloid versus colloid. الكريستالويد اللي هم النورمال سلاين واللاكتيتد رينجر، والكولويدز اللي هم الالبيومين، ما في فرق بينهم. اوكي. طبعا ممكن نستخدم بريسورز اللي هو زي النور ابنفرين اذا اعطينا المريض كميه جيده من السوائل. اوكي. طيب كم حاعطي انا سوائل؟ I will give 1 liter crystalloid equal to 1 liter of colloid. يعني في الإفكت والستابيليتي 250 مل ألبيومين يساووا 1 لتر صلاين. أوكي. بس الكريستالويد cheaper. We should transfuse blood if hemoglobin is less than 7. أوكي. ليه؟ لأنه الأكسجين يحمل للخلايا على الهيموغلوبين. فلما يكون عندي أنا severe drop in hemoglobin I have to transfuse blood، وما أستخدم الفريش فروزن بلازما ولا الكواجيول عشان الفوليومز، هذه فقط تستخدم في حالات الكواجيولوباثي. طيب هذه بالنسبة للهايبوفوليميك شوك. إذا أهدافنا في الهايبوفوليميك شوك to control the hemorrhage, stop the cause of loss of fluid and compensate. اوكي. اللي هو replacement. وتذكر انه اذا كان المريض عنده excessive loss of blood saline alone is not adequate. ولو سألتني هذا السؤال ليش، if you ask me why I will tell you that saline does not carry oxygen. okay. it is hemoglobin that carries oxygen، والهيموغلوبين موجود في البلد. طيب ننتقل نتكلم عن الكارديوجينيك شوك. الكارديوجينيك shock it is the heart inability to pump enough blood to meet the body oxygen demand. الآن المشكلة وين؟ إنه القلب ما يضخ. أوكي. can be systolic or diastolic, can be left or right side, can be acute or chronic. فأنا عندي يمكن systolic acute heart failure أو chronic systolic heart failure. أوكي. decrease cardiac output هي أهم شيء. وكيف نقيس الكاريك اوتبوت؟ إحنا نقيس الكاريك اوتبوت نحتاج لإيكوغرام. أوكي. نحتاج إن نطلب للمريض إيكوغرام to determine إنه الكاردياك function is deteriorated. The cardiac echogram they will measure the diastolic volume, or they will measure the systolic volume, or they will identify the stroke volume, and they will estimate the ejection fraction and the cardiac output. Okay, so that's why echogram is very good and quick, non-invasive cardiac diagnostic tool. طيب ببساطة مريض عنده cardiac failure حيكون عنده decreased cardiac output، حيكون عنده peripheral vasoconstriction، وحيكون عنده decrease in left ventricular stroke work. The stroke volume and cardiac output will drop. Okay. طب احنا قلنا systolic, diastolic, left sided or right sided. What are the causes of heart failure? Left ventricular infarct, right ventricular infarct، pulmonary embolism. والpulmonary embolism ايش بتسوي؟ بتعمل block of the blood so the blood cannot reach the lung. اوكي. cardiac tamponade اللي هو احتشاء خارجي اللي هو تجمع السوائل في الغشاء اللي يحيط بالقلب. اوكي. ممكن endocarditis with mitral valve تعمل obstruction و left ventricular tachycardia. اوكي زي البيتات. طيب الكوروناري برفيوجن مهم، فاحنا نحتاج دائما ان نزود الكوروناري، والكوروناريز يعتمدوا على الديستوليك بلود بريشر. واي مريض عنده فول to meet the demand, okay, we have to improve the cardiac function, we need to give fluids. Remember, aortic diastolic pressure drives coronary perfusion. فالمريض اللي عنده decreasing coronary perfusion نحط له something we call it intra-aortic balloon pump. وهذا الانترا ايورتيك بالون بامب عباره عن بالون يملأ بالهيليوم، اوكي، ينتفخ في بدايه الديستولي ويتنفس ببدايه السيستولي. وظيفته انه يزود الكوروناريز بمور بلاد سبلاي. اوكي طيب الفنتريكولار dysfunction limits a patient ability to perform routine activity of daily life. اوكي هذا في الكرونيك كارديوجينيك فيلير. فدائما مرضى الكرونيك هارت فيلير نمشيهم على ديوريتكس و AC inhibitors to reduce number of sacs on the wagon، يعني ننزل الفوليوم. طيب هنا سؤال، الديوريتكس اللي نستخدمها زي الليزكس يأثر على البوتاسيوم، فأنا مفروض إني أعطي المريض ديوريتك زي الألدكتون يعمل ديوريسز لكن ما يأثر على البوتاسيوم، ولازم دائما نراقب البوتاسيوم حق المريض. ال AC inhibitors اللي هم الانجيوتنسين converting enzyme inhibitors أو الانجيوتنسين ريسبتور agonist، أوكي، هذول يمنعوا شغل اللي هو الالدوستيرون. الالدوستيرون هرمون يفرز من اللي هو الغدة الفوق كلوية من القشرة، وظيفته انه يحبس الصوديوم. فاحنا غالبا نحارب احتباس الصوديوم عن طريق الاي سي inhibitors. اوكي طيب دايما التاكيكارديا is gonna consume more oxygen و increase the cardiac demand and damage. That's why majority of heart failure patients are on beta blockers and calcium channel blockers in order to decrease heart rate. Okay? طيب or control heart rate. الكاردياك resynchronization therapy اللي هي إعادة تضبيط القلب. فممكن القلب يحتاج لبيس ميكر إذا كان عنده براديكارديا أو أريثميز. ممكن نحتاج something we call it left ventricular assisting device. هذه عبارة عن مضخة خارجية تزرع طرفها في الليفت فنتريكل والطرف الآخر ينحط بالأيورتا، أوكي، والطرف الآخر ينحط بالأيورتا. هذه اسمها left ventricular assisting device. الآن اخترعوا بمب جديدة اسمها إمبالا تأخذ الدم مباشرة من الفنتريكل على الأيورتا، أوكي. والحل النهائي اللي هو الهارت ترانسبلانت. اوكي طيب الديستريبيوتيف شوك اللي هي من اسباب الهيموديناميك انستابيليتي السبسس والانافيلاكسس والاكيوت ادرينال انسفشنسي اند نيوروجينيك دامج، اما نيوروجينيك هيد او نيوروجينيك سباين. اوكي الان في هذه الديستريبيوتيف شوكس كلهم يتميزوا بقضية قضية مشتركة اللي هي الفيزو دايليشن. هذه الشوكس تشترك كلها بتوسع الشرايين. اوكي what are the signs؟ decrease cardiac output و decrease systemic vascular resistance. يصير في severe vaso dilation، that's why they are associated with hypotension. اوكي طيب كيف السبسس تحصل؟ تدخل بكتيريا أو فيروس أو فنغس أو باراسايت على الدم وتعمل لي سبسس. في هذه الحالة في ظل وجود البكتيريا والمخلفاتها، يعني in the presence of bacteria and its waste, this is going to stimulate our systemic immune system and this is going to develop SARS. SARS يعني systemic inflammatory response syndrome. اوكي علامات السيرز فيفر، تكيبنيا، تاكيكارديا. اوكي وهذول هم الايرلي وارنينج ساينز فور سيبسيس. طيب احنا دورنا ان نمنع السبسس عن طريق منع الانفكشن. If the patient has septic signs, we can activate RRT in order to start the management. Okay? A septic shock is caused by the systemic release of mediators that usually triggered by circulating bacteria or products. وجود البكتيريا تعمل ردة فعل مناعية ويروح جسمنا اللي هو عن طريق الإيزينوفيلز. It will spit الهستامينز وهذا الهستامين يعمل severe vasodilation. ولما يصير عندي severe vasodilation مع وجود الحرارة والالتهاب يدخل المريض بسيفير hypotension. Okay? It is referred to hypotension must be present. لما نقول refractory hypotension يعني المريض عنده hypotension عطيته fluid challenge still he is hypotensive. This is what we call it refractory hypotensive. يعني it is hypotension that is not responding to fluids. يعني المريض عنده انخفاض في الضغط وما يتجاوب مع السوائل. Okay? Clinical manifestations of shock, hypotension, oliguria, decreased mental status, decreased peripheral pulses, diaphoresis. وهذه كلهم مجموعين نسميهم multi organ dysfunction syndrome. Okay? Shock goals treatment. Initiate fluid resuscitation. تعطي 20 إلى 30 ml per kg over the first hour. Stabilize hemodynamic. مريضك ما تجاوب على الفلويدز you have to start norepinephrine. اوكي او اللي هو نور ادرينالين. Treat the infection. Take blood culture و start antibiotics as soon as possible. You have 1 hour to give your initial dose of antibiotic. وانتربت ميدياترز. فإذا المريض ما تجاوب على الفلويدز والاينوتروبس ممكن نعطيه كارتيزون in order to interrupt the mediators. Okay? A septic shock initial resuscitation, appropriate large volume of fluids. فأهم شيء في مريض السبسس إني أنا أعطي volumes. Okay? هذه أهم شيء in order to achieve a high level of central venous pressure. طيب. We recommend fluid resuscitation with either natural or artificial colloids or crystalloids. يعني normal saline lactated ringer or with albumin. Okay? There is no evidence base to support type of fluids on another. يعني ما في إثبات إنه الألبومين أحسن من الصلاين. Okay? Stabilize hemodynamic. فتبدأ على نور ابنفرين. Okay? وتحط للمريض arterial line في الآي سي يو. ومينتين good oxygen delivery. maintain good oxygen delivery. متى نعطي دم في مرضى الشوك؟ نعطي دم في مرضى الشوك إذا كان الهيموغلوبين less than 7. We only give hemoglobin if patient has hemoglobin of less than 7 because our goal is to restore the volume, and here I have loss in volume and loss in hemoglobin. So I need to improve oxygen saturation. Okay, I need to improve tissue perfusion and tissue oxygenation. So I need to have adequate hemoglobin. Okay. طيب. النورابنفرين دوز نبدأ ب 0.2 to 1.5 microgram per kilogram وممكن تعطي larger doses. Okay. الادرينال كرايسيس اوكي. الكوز اوف ادرينال كرايسيس اوتوميون ادرينالايتس. يدخل مريض بالتهاب الغده الفوق كلويه. اوكي. ويفقد مقدره الجسم على افراز الكورتيزون. اوكي. الادرينال ابوبلكسي زي الهيموريج اور انفاركت وهذه ممكن يسببها الهيبارين. اوكي. يعني يصير في تلف في الغدة الفوق كلوية المسؤولة عن إفراز الستيرويدات. Okay? Steroids might be life-saving in the patient who is unresponsive to fluid, inotropic and vasopressor support. طيب فأي مريض عنده decrease or shortage of cortisone in his body, he is not gonna respond to vasopressor and fluid therapy. So in this case, steroid is a life-saving for this patient. تعتبر إبرة الكورتيزون منقذة. وإحنا غالبا في البراكتس if the patients get fluids started in inotrope did not improve blood pressure we give him cortisone as a stress dose. اوكي طيب نتكلم الحين عن الانافيلاكسس اللي هي ردة فعل التحسس اللي هو الالرجيك رياكشن. اوكي caused by allergic reaction to allergen with the most common cause are blood products, antibiotics and vaccines. بعض الناس عندهم حساسية للحشرات وبعض الأطعمة. أوكي إيش هي ال early signs of anaphylaxis؟ itching, redness and swelling. يبدأ المريض يتحكحك ويحمر جسمه ويبدأ يتنفخ شفتين المريض وحلق المريض. أوكي والليت signs congested face, tongue and airway, respiratory distress, he is showing signs of shock. وهذا الانافلاكسس خطير. اوكي لانه احيانا تيجي ردة فعل المناعة في موقع انت بعيد جدا عن الرعاية الصحية، في مطعم، في مول، في حديقة. دائما لازم يكون في عندي انافيلاكسس بروتوكول، والانافيلاكسس بروتوكول يقول لك if the patient started signs of allergy اول خطوه ايش نسويها؟ يتوقع هذا السؤال نقدر نجاوب عليه. انا بلشت مريضي على دم وبعد شوي او بلشته على كيموثيرابي او بلشته على اي اذر ميديكيشن انتي بايوتيك وشوي بلش المريض يصير عنده ريدنس وإتشنج. أول خطوة نسويها إن إحنا نوقف هذا العلاج. We have to stop that medication or that drug first. Second, you start normal saline. Third, you need to give the patient hydrocortisone and Benadryl. If the patient did not respond or he started to show signs of respiratory allergy زي الtongue is swelling والصوت المريض صار متحشرج وصار في عندك wheezes, you have to give the patient epinephrine. طيب السؤال ايش هو وظيفة الابنفرين؟ الابنفرين معروف انه هو بيتا 1 اجونست لكنه H1 بلوكر. اوكي الابنفرين يغلق مستقبلات الهستامين فيوقف عمل التحسس. اوكي فذاتس why epinephrine is important. طب الأوبستراكتيف شوك، طب لا خليني ارجع بس على الانافيلاكسس. بعض المرضى يدخلوا بكاردياك ارست او سبير شوك، في هذه الحالة لازم نعطي الابنفرين اي في ونبدا فلويد وي كان كود ذا بيشنت. اوكي الأوبستراكتيف شوكس caused by cardiac tamponade, tension pneumothorax or massive pulmonary embolism. اوكي الكاردياك تامبوناد اللي هو تجمع السوائل حوالين عضلة القلب، والتنشن نيموثوركس اللي هو وجود هواء داخل البلورا، والماسيف بالمونري امبوليزم عبارة عن فترة قفل مجرى الدورة الدموية من القلب إلى الرئتين. اوكي decrease cardiac output وسيفير vasoconstriction. اوكي هذا الكارياك تامبوناد نورمالي هيلثي هارت. احنا في عندنا غشاء يحيط بالقلب، اوكي يسموه غشاء التامور بالعربي. اوكي فالتامبوناد هو تجمع سوائل داخل هذا الغشاء. فهذه السوائل راح تضغط على القلب وتقلل مساحة القلب وتمنع رجوع الدم للقلب وتمنع القلب من الامتلاء بالدم. This is gonna compromise the heart, is gonna decrease the filling of the heart chambers, and this is gonna decrease cardiac output, or the patient is not gonna be responding to any therapy. Okay, so you have to be very careful with that. The treatment, as you see, there is a surgical procedure to evacuate the fluid around the heart, and the patient is gonna improve. Okay. Intention pneumothorax هو عبارة عن تجمع الهواء في حجرة اللي هو خارج الرئة في البلورا. This is a fluid, not a fluid. This is air occupying the pleural space is gonna push the lung and will push the heart and will decrease cardiac diastolic function. But the patient will go in signs of shock. Okay, اللي هي نسميها الobstructive shock. لأنه نفس مبدأ التمبوناد إيش يعمل؟ يمنع رجوع الدم للهارت. فيو cannot fill the vessels. وهنا نفس الطريقة. أوكي؟ هنا نفس الطريقة. فيدخل المريض بديكريز diastolic volume, decrease contractility, decrease cardiac output ويعطيني signs of shock. والcompensation دايما تكيبنيا and tachycardia. أوكي؟ السباينال فيرسس نيوروجينيك شوك. لما اقول سباينال هنا نتكلم عن قطع وتوقف تزويد السمباثيك نيرفس سيستم. اوكي، طيب في حالات السباينال شوك لما يصير في قطع للحبل الشوكي فوق الثوراسيك 8. اوكي، when a trauma to the spinal cord above thoracic 8 lead to cut on the cord, this is gonna stop the sympathetic supply. Okay. طيب. In the neurogenic, sudden loss of sympathetic nervous system signal because of head injury, mainly for the hypothalamus. Okay. طب ايش اللي حيصير في الحالتين؟ يعني انت هنا فقدت الارسال من السمباثيك نيرفس سيستم. اوكي. الهايبوتنشن، براديكارديا، بلبو كافيرنس ريفلكس هذا في الاي، حيصير في عندي فلاسيد باراليسيس. في النيوروجينيك ما حيكون. التايم 48 to 70 42 to 72 hours immediate after spinal cord injury. اوكي. الميكانيزم peripheral neurons become temporarily unresponsive و disruption of autonomic pathways. اوكي، هذا بالنسبه للنيوروجينيك. اند ايش اعراضها؟ اوكي، حيصير في عندي براديكارديا وديكريز كاردياك اوتبوت وسيفير هايبوتنشن. اوكي، طيب الان types of shock cardiogenic. الانسلت fail heart to pump blood, decrease cardiac output. حيصير في عندي increase systemic vascular resistance، يعني حيصير في عندي severe vasoconstriction. اوكي. في الobstructive shock heart pump will but the outflow is obstructed. اوكي، the outflow is obstructed. حيصير في عندي decrease cardiac output. في الهemorrhagic shock الهارت is pumping well but the volume is lost. حيصير في decrease cardiac output و increase systemic vascular resistance. في الديستريبيوتيف اللي هم السبتيك والانافيلاكتيك والسباينال شوكس حيصير في عندي severe vasodilation مع براديكارديا في نيوروجينيك شوك و decrease in contractility نيوروجينيك شوك. فحيصير في عندي decrease in systemic vascular resistance مع المحافظة على الكاردياك output، مع المحافظة على الكاردياك output. اوكي، فهذه سمري لكل الشوك والهيمودايناميك انستابيليتيز اللي ممكن نتعرض لها. اوكي، اثناء شغلنا مع المرضى. و our main goal is always to establish في الانافيلاكسز remove الالرجين. يعني اذا المريض يتحسس من دم اوقف الدم، يتحسس من علاج اوقف العلاج. اوكي. النقطة الثانية بالنسبة للهيموريج we have to stop the hemorrhage. اوكي، مريض عنده bleeding we have to control the bleeding حتى لو كان surgical bleeding. اوكي. مريض عنده سبسس الهدف الأول إنه to start antibiotics because you have to stop the cause of septic. أوكي، فهذه مهمة جدا. مريض تمبوناد لازم تشيل التمبوناد. مريض نيوموثوركس you have to treat التمبوناد. أثناء إجراءاتنا من أجل التخلص من العرض الأساسي أو السبب الأساسي. we have to maintain IV access, we have to give patient fluids, we have to give the patient vasopressors, we need to give the patient cortisons in order to improve their cardiac output and their blood pressure in order to maintain and preserve oxygen to the body. Any patient is complaining of hypoxia, respiratory problem, we need to improve and optimize oxygen supply by maintaining patent airway, supplying oxygen. If you need to intubate and put the patient on mechanical ventilator, you have to do that. Okay? I think that's all. Okay? For adults. Now we will come to the pediatric part. Okay? في البيدياتريك part, this is from Pulse, management of shock flow chart. أول شيء تعطي oxygen, pulse oximeter, ECG monitor, IV access, okay, BLS as indicated إذا تحتاج تعمل CPR and point of glucose testing عشان ما يكون عند المريض hypoglycemia. طيب في الهيموريجيك شوك نركز هنا على الهيموريجيك شوك. إذا نون هيموريجيك أوكي نعطي 20 ml per kg normal saline and repeat as needed وconsider colloids. أوكي طيب إذا إنه هيموريجيك control external bleeding هذه أهم شيء ونعطي نفس الشيء 20 ml per kg bolus repeat 2 to 3 times as needed وترانسفير blood product if indicated. فإذا كان المريض عنده هيموريج والهيموغلوبين منخفض ممكن أن نعطي المريض blood. أوكي طيب في الديستريبيوتيف شوك أنت عندك أو عندكم مع بعض septic shock manage algorithm as septic shock. وإحنا شفنا الالجوريثم of septic shock اللي هو give fluids treat the cause give antibiotics. اوكي بالنسبه للانافيلاكسس الاي ام ابنفرين مع فلويد بولس. اوكي وممكن نعطي البيوترول وانتي هيستامين corticosteroids and we can start infusion if the patient is not responding. If neurogenic نحتاج ل 20 ml per kg normal saline repeat PRN وممكن نحتاج vasopressor ممكن يحطوا المريض على ادرينالين فيزوبريسين. بالنسبه للكارديوجينيك شوك if bradycardia او tachycardia we have to manage bradycardia and tachycardia with poor perfusion according to the algorithm. فالبراديكارديا ممكن نعطي اتروبين او دوبامين او ابنفرين والتاكيكارديا we need to control the rate and convert the rhythm. إذا other يعني زي congestive heart failure, myocarditis, cardiomyopathy, poisoning 5 to 10 ملغ kg saline اوكي vasoactive infusion وconsider repeat consultation. اوكي يعني تحتاج لكاردياك consultation. بالobstructive shock إذا ductal dependent prostaglandin في مرضى يكون عندهم patent ductus arteriosus اوكي ممكن تعطي بروستاجلاندين وإذا تنشن pneumothorax needed decompression مع chest tube وكاردياك تامبوناد pericardiosynthesis مع fluids وpulmonary embolism 20 ml saline وconsider thromboembolic to treat the pulmonary embolism. Okay. That's it for the presentation. This is the end of the presentation. Thank you very much. شكرا جزيلا. This is how we manage patient hemodynamic instabilities and shock. If you have any question, I am ready to answer. If you don't have any questions, we are done for today. Thank you very much. هذه كانت آخر محاضرة. This was the last presentation. Okay. الله يعافيك حياك الله. I'm still on the line. If you have any question, please. Okay.